All right, let's get started. Good morning, everyone. I'd like to welcome you to City of Hope's first ever mental health symposium. My name is Christian Port, and I am one of the co-chairs of City of Hope's Community Benefits Advisory Council. Before we get started, I wanted to share with you a little bit about the council, go over a couple of housekeeping items, and because this is our first ever symposium, let you know a little bit about what you can expect from today. First of all, how awesome is it that a cancer hospital is hosting a mental health symposium? Right? Amazing. And if you're like me, you're probably wondering why. And if not, I'm going to tell you anyway. So it started with our Community Benefits Advisory Council, and we are not your typical rubber stamping advisory council. Taking their tasks seriously and intelligently, our council ensures that City of Hope's community benefit programming addresses our community's top healthcare needs and priorities through our community health needs assessment, implementation strategy, and our Healthy Living Grants program. This year, mental health rose to the top of our list. This may indicate that mental illness has finally reached a level where it impacts almost everyone in our community. In fact, nearly 75% of the communities that we serve express that there is an insufficient amount of community resources to address mental health. Our community members and the council have spoken. It is time to address the ways that mental health impacts our ability to fight chronic disease and cancer, and that is why we're here today. So thank you for being with us. Around the room today, you will find primary care providers, specialty care providers, mental health experts, public health professionals, and more, all here to answer the question, how do we help the broader community increase access to mental health services that are culturally and linguistically appropriate? We encourage you to network, exchange ideas, and learn from our community organizations. We have set up a networking break and resource fair so that you will have plenty of opportunities to connect with each other. A couple of final housekeeping items. Bathrooms are located directly across the way. You'll see the giant signs, or miss them like me if you haven't had coffee yet. We will have our first networking and refreshments break at 11:30 following our first two panels. And after our final two panels, we encourage you to stick around for our networking and resources fair from 1 to 2 p.m. We encourage you to take notes while our panelists are speaking and to write down any questions that you may have. We will have designated time during the panels for Q&A. We appreciate you silencing your cell phones, and please refrain from talking while our panelists are speaking. So without further ado, I would like to introduce our keynote speaker, Mickey Carpenter. Mickey is currently the Director of Recreation and Family Services for the City of Azusa. She is a social ecologist and public health professional by training and has worked in multiple sectors, including healthcare, nonprofit, higher education, business, and government. Using these experiences, she strives to develop cross-sector solutions to build community health, and currently does so by serving as chair of the Healthy San Gabriel Valley Initiative. Please join me in welcoming Mickey to the stage.
Okay. Great. Well, thanks everyone. It's really great to see you. I stand before you as a proud Community Benefit Advisory Council member. City of Hope is doing amazing work, and our fearless leader Nancy here, along with our wonderful co-chairs, are doing such amazing things that I'm just really excited to be here and representing this group. I'm also really excited to be representing Healthy San Gabriel Valley, and I'm going to share with you a little bit more about that as well. We will be talking some about the importance of collaboration. I know we're here to hear about navigating through mental health services in the San Gabriel Valley or in the region or in LA County. And we all play a role in that, but it's really important for us to also think about the system and how we create more efficient, more effective systems, not only regionally, but also locally. And that's why I'm here to share a little bit too about what we're doing in the city of Azusa, which we hope other communities will do as well, and how we can plug into regional efforts too. So Healthy San Gabriel Valley is a regional initiative to create a healthy, safe, and resilient San Gabriel Valley. Before we dig in to talk a little bit about that, I do want to talk about what impacts health, Many of you have maybe seen this diagram before. There's different versions of it. Oftentimes there are some great graphics identifying the social determinants of health and really describing all of the different factors that address or that impact health outcomes. This is really nice because it kind of quantifies for us the different factors that actually impact health outcomes. And if you take a look at this, clinical care, which includes access to care and quality care, impacts health outcomes by about 20%. And then things like education, employment, income, family and social support, and community safety actually impact our health outcomes by about 40%. So the collective of those two things are 60% of these different factors impact how healthy or how unhealthy we may actually be. And when we talk about health, particularly for Healthy San Gabriel Valley, we are talking about a very broad definition of health that includes all of these various factors. We talk about them as social determinants of health and public health, and other professionals use lots of other language around it. I call them the squishy factors. They are the things that are very hard to define, they're hard to measure, but we know they exist and we know they're very complex to address. Because these factors, and we're talking about things that are really systemic, things that, things like poverty and oppression and various factors about communities are really hard to address. No one agency is going to be able to address all of these factors alone. So they require very different types of solutions. Some of those solutions require creating very impactful and efficient collaborations well beyond networking. We're talking about trying to create systems change. And that's what we're trying to do with Healthy San Gabriel Valley. One of the most important things to consider for our talk today is the fact that those social and economic factors and things related to health access are all things that intersect with mental health and mental health services. It's no coincidence that the City of Hope Community Benefit Needs Assessment identified mental health as a key priority area, because we also know that all of the other major health systems in the area identified mental health for the first time, in many cases, as a priority too. So this is really powerful information. And the Health Consortium of the San Gabriel Valley convened a meeting earlier this year, and Nancy serves on that task force as well, and where all of these hospitals that sometimes do compete actually came together and shared their health needs assessments and talked about the importance of these complex issues, and particularly how mental health kind of rose up as a key priority for them, even though the services they provide may be classically healthcare. So what is Healthy San Gabriel Valley? Healthy San Gabriel Valley is an initiative that really began to form about a couple of years ago. There have been lots of involvement, and Azusa Pacific University and again, many of the hospital systems were involved in, and the YWCA was a big part of formulating where we are today. And the most important thing to think about when you think of Healthy San Gabriel Valley is that it is a cross-sector collaboration. It's not a collaboration of folks who just work in healthcare or just work in mental health or just work in social services. We think it's really important that all of these different sectors work together because the issues that we're trying to address are so complex. We cannot do it alone. So right now, the way it operates is through a steering committee. Typically, one of the big things that the group has focused on over the last couple of years are convenings. We know that in order to address systems change, the very first thing that has to happen are conversations. So the YWCA has served as a backbone organization. Many other organizations have participated, as I mentioned, Azusa Pacific University, the San Gabriel Valley Economic Partnership, the City of Hope, along with Citrus Valley Health Partners, all have been big players in putting on some of these activities. And so one of the most important things, again, is the systems and network capacity building. So this very first box here, Roadmaps and Intersections, has been a conference that has been going on for the last 3 years, as well as quarterly convenings. Very similar to this, and really excited to see this emphasis, and many of our Healthy San Gabriel Valley folks are here today to take part in this. I just learned that First Five is again going to sponsor and support the Roadmaps and Intersections Conference. So that will be happening again in December. So we'll be sending you more information about that as being a participant in this program today. There are also wonderful local projects that we like to plug into this regional effort so that we can learn from local efforts and be able to disseminate that information. Some of what I get to work on now, being a representative of the city of Azusa, we have a wonderful health neighborhood program, or excuse me, a neighborhood connections program. Health neighborhood, I think you might hear from Evelyn over there, which is another fantastic collaborative effort. But the Neighborhood Connections program at the City of Azusa is a way that we're trying to work in a cross-sector manner, even within our own city. So we actually have social workers that work in our library to be that front line of access to information and referral services. And we're trying to work with other providers in the community to be able to do better referrals, warm handoffs, and to do expedited referrals to those agencies that can help work with us. We also have our HALO program, which is where our police department works directly with some clinicians from the Department of Mental Health, which has been very successful. So that's an example of some local projects. There's fantastic examples as well that we often share at our conferences. Because again, we think it's really important that we share and disseminate those success stories. Then the San Gabriel Valley Economic Partnership is taking the lead on our regional campaign. We want to make sure that people understand that the San Gabriel Valley is a wonderful place to live, work, and play. And they will be launching later this year Healthy San Gabriel Valley Cities designation. And so we're really excited about that. There's actually going to be a convening of cities within the San Gabriel Valley that will be coming together to move forward that effort and to also share best practices among cities. So how are some ways that we can align efforts for greater impact? I just shared with you some local things that are happening that tie directly into Healthy San Gabriel Valley. What you might not know is that early on, we worked really closely with the LA County Department of Public Health so that we could make sure that Healthy San Gabriel Valley goals aligned with the Community Health Improvement Plan of LA County. We also know that this CHIP plan ties into the California Wellness Plan as well as Healthy People 2020 national objectives. Why is this important? It's important that we all have a shared vision. It's important that all of our movements, all of our programs are all aligned with similar visions so that we can all collectively move forward. There are many ways that we can align the work that we do. Some of it is in participating in things like this today, understanding our colleagues, not just within our sectors, but across sectors. So networking is really important. Data is also very important. Access to data and being able to communicate what those results mean is very important. Having that shared vision, I just can't stress that enough. Being able to understand that we don't have to be competitive in accessing clients or consumers or patients or folks out in the community. We all are serving the same people. And being able to take on more of a collective impact model in what we do, knowing that with a shared vision and understanding our role in attaining that is very, very important. There is enough need to go around. Most important, as I mentioned, the best way that we can align is really in our own minds understand that if we are a social services provider and we see our clients, if we are a mental health provider and we serve consumers, if we are a healthcare provider and we serve patients, and from where I sit now working in a city, we serve residents. Again, they are all the same individuals and we can all work together to help serve them better and help them navigate through the mental health services in the San Gabriel Valley better. Thank you very much for having me today, and I hope you enjoy your day. Thank you.
All right, and now we're going to invite our first panelists to the stage. Our first panel is going to be on trends for major depression in LA County, understanding mental health data and definitions. Mental health issues are oftentimes the underlying factor that prevents someone from achieving good health. But in a society that is constantly changing, how do we define mental health? What data do we need to be looking at in our communities? And how do we incorporate mental health into our practices as providers? With us today, we have Nancy Clifton-Hawkins. Come on up to the stage, Nancy. Nancy is the manager of community benefit at City of Hope. She's a Master of Certified Health Education Specialist and has spent the last 20 plus years working to address health inequities in Southern California and abroad. Currently, she is the chairperson of the Mindfulness Center located at the Orange County Buddhist Church.
Thank you. I'm also the timekeeper. So let me get this started. There we go. I'm so happy all of you are here today. Just an idea, if any of you are on social media, at City of Hope, hashtag Mental Health Symposium, that would be really great if you're taking pictures, that we can share that with the broader community. I also wanted to let you know that for those of you who registered before last night, I sent an email out that gave a link to all of our presentations. I'll update that because some of our presenters did make some revisions to it. And also there were handouts that we had that I didn't get back from the print shop in time that I want you to have as well, and I'll be posting those on there. So please go back to that. And if you registered today, make sure that you gave your name and email address so that I can continue to add you to that listserv so that you can get that information. So, all right. I think we all already know this, right? Mental illness is among the highest of all diseases. I think we all know it's been around for hundreds and hundreds and hundreds and hundreds of years. I just don't think that we've had the capacity to really recognize it or to remove the stigma or to address our fears. It's been here for eons, right? As long as people have been around, there have been mental illnesses. It's the most common cause of disability. It is the 11th leading cause of death in the United States for all age groups, and it's the second leading cause of death among people ages 25 to 34. Any guess why? Exactly, suicide. So nearly 20% of US adults suffer from any mental illness, and about 4% have a seriously debilitating mental illness. So from the national level and bringing it down to California, you can see that 1 in 6 adults are diagnosed with a mental illness as of 2014, and I'm certain it's probably changed since then. 1 in 25 have actually had a serious mental illness. For children, 1 in 14 had a serious emotional disturbance. And then the substance use disorders, and these are a little bit old in the stats as well, but 11 drug overdose deaths per 100,000 persons. And as you can imagine, in rural counties, rates were double the statewide average, right? I think right there, that's the glaring example of the opiate epidemic. So in 2015, in LA County, we had a number of people who had major depressive episodes. And when you compare that with the US, 6.7 adults had a major depressive episode, but in LA County, 8.6% of the adults did. And when you break that down a little bit more, for women it was 8.5% on a national level, but for women in LA County it was 10%. And then for men, 7.1% versus 4.7%. So why do you think we're showing better or higher stats for women than we do for men? What's that? Exactly. So to me, that says we need to get that number for men higher, so that means they'll be self-reporting or at least getting into care, right? So let's break it out by the spas. You know, LA County is broken down into a lot of special population areas. So when we look at the major depressive episodes in LA County, remember that's 8.6 at the highest level. Then think about geographically where a lot of our other spas are located. Antelope Valley, Spa 1, Lancaster, Palmdale, 12.5%. San Fernando Valley, 8%. San Gabriel Valley, where we're sitting right here, 6.4%. Metro LA, 10.8, West, 11, South, 8. East 8, South Bay 8. So you may say, wow, why are those numbers so different in a lot of different places? Well, look at the areas of health disparities and inequity in access to healthcare services, and maybe higher rates of individuals dealing with those social determinants of health that put them at a greater risk for depression and other mental health issues. Antelope Valley, that's way out there, right? And it's a very disparate population with access issues. Metro, that's like right in, oop, look at that. I didn't know I could do that. That's amazing. It's a touch screen. Okay, so I just, when you read these, I'm really easily entertained. So when you look at all these numbers, please keep in mind, not just those numbers, but think about it in your mind. Where are these cities located, and what makes those populations so different that increases their risk? And you might be surprised at the answers you find. Now, at risk for depression is different than having a major depressive episode. So when we look across ethnicities here in LA County, we see the highest number in American Indian and Alaska Natives, followed by African American, and then Latino at risk for depression. Again, what I just said about geography and where a person lives also has to do with their race and ethnicity, right? We know, it's a fact nowadays, there's no getting around it, that people of color deal with more stressors that increase their risk for major depressive episodes. And so we need to start looking at different ways that we can put care and services into the hands of those communities that address fears and barriers and stigma so that we can get the help that they need. Again, I just did the breakdown for LA County, and you can see the different SPA regions and how those numbers change. We see more people at risk than the ones that actually have the reported depressive episodes. So for children, we can't not look at this number, and there's been a lot of news out there about suicide in the adolescent population. So in the US, 12.8% of children ages 12 to 17 had a major depressive episode. The target in the US is 7.5%, so we have a lot of work to go, don't we? Among adolescents, 12 to 17, females, of course, had a higher rate, which is about 3 times higher than the males. Think about young teenage girls or tween girls and the issues and the emotional things that might be going on, but also other factors like self-esteem or bullying or first heartbreak or issues in the house. And then we go into the other social determinants of health, and we see this number is exploding. But there's good news, right? The numbers are kind of scary, but there's good news. And right here in LA County, there's some incredible preventive early intervention programs. And I wanted to share this from a RAND report that came out this year in their program. So the kids are staying well. Once they're getting into care, they're actually staying well. So that tells us, well, we need to get them into care then, right? And we need to provide programs and services that help sustain those changes. And that those kids are actually getting better. When you look at the second one, you'll see 5 out of 10 no longer had a clinically significant symptom over time. So that's good news, right? So we have an opportunity right here to think about all of us in this room and the networking that we can do, and how can we create early intervention programs and sustain those efforts so that our next generation of citizens will have healthier mental health. But the question is now, how are we going to meet that need, right? Well, this came from the Health Force Center at University of San Francisco, and they talked about the current behavioral workforce stat. And the bottom line is we don't have enough professionals out there to meet the need, especially in our larger rural areas. They found we have a lack of diversified workforce, especially for those who are psychiatrists or psychologists in our populations of color. A lot of our psychologists and psychiatrists are retiring, and there's no one there filling the ranks to take care of that. And then when we look at our behavioral health trainees across the state, we're not pushing them into other areas. They're congregating in a lot of the same places. So the care that people could benefit from by having these trainees provide services in other nonprofits or county facilities, they're not getting out there. So I think we need to kind of figure out how we're going to change these stats. We will have 41 fewer psychiatrists by 2028, and we will have 11% fewer psychologists, MFTs, LCSWs, and so forth. So we need to be the change. All of us in this room, when we look at these stats, I always like to look at things with our glass half full rather than half empty. Oops. So I want you to think about these things when we have our panel discussions and when we network, but mostly take these thoughts with you go home. What can be done to better address the needs of the populations that you serve? Have you seen or heard of any promising interventions that can address mental health? Because you know what? The old way that we've been doing it hasn't been doing it. We need innovative thinkers to not think within the box, but not care about a box. And if it works with your population, be brave enough to stand up and get those networks together so you can make that difference. And then what do you need to make that move? As Christian mentioned and Mickey mentioned, we're looking at investing in mental health. Barbara Dickerson is here with Janet, Congresswoman Napolitano's office. We've got Kaiser here and other ones that are looking at doing more to make a difference in mental health. But we need your innovative ideas. Come to us, talk to any of us, and let us see what maybe we can do to bring these things to fruition. And then just in closing, I like children's books. I have a huge collection of them. And this one is the 3 questions based on Leonard Tolstoy's story. And he asks these 3 questions. And he says, what is the best time to do things? Who is the most important one? And what is the right thing to do? And I would like to venture to say, the best time to do things is now. Who is the most important one? Well, for me right now, it's all of you in this room. And what is the right thing to do? It's what we're all doing here today together. So thank you very much.
Thank you, Nancy. That was amazing. All right, and now I'd like to introduce Dr. Jaroslava Salman. Dr. Salman is a chief of psychiatry at City of Hope, and her specialty is in consultation liaison psychiatry. Welcome.
Good morning. I go by Yara, if you want to talk to me afterwards. Welcome to this conference, and Nancy, thank you so much for organizing this. I will brag a little bit to start with. I am one of the 3 full-time psychiatrists here at City of Hope. So City of Hope, that tells you that City of Hope as an institution really appreciates the importance of mental health and the importance of mental health care for their patients here. We have also 4 psychologists, full-time psychologists. So the support here for mental health needs is amazing. But it is an exceptional place. So unfortunately, that's not the case at every cancer center around the country. I'm here to talk to you about depression in primary care setting and the realities of it. But allow me to talk just a little bit about mental health issues in primary care in general. We know that 20 to 40% of primary care patients have some kind of behavioral disorder. And more patients actually receive treatment for mental disorders in the primary care sector rather than in the mental health specialty setting. That's one of the realities. I don't think I have to convince you that the healthcare expenditure in the United States is the highest in the world. Are we the healthiest people in the world? Far from it, right? 10% of our patients consume over 60% of the healthcare dollar. And these are usually complex patients who have comorbid chronic medical and mental illness. Primary care patients who have one chronic mental condition are twice as likely to have a psychiatric illness. If they have 4 or more chronic medical conditions, they have 5 times rates of psychiatric illness. And you can see the rates in percentages on the right. And then if you are in the primary care world, you know that your patients, many of your patients have issues with chronic pain, obesity, cancer, neurological disorders, heart disease, and diabetes. Up to a quarter of adults will have a major depressive episode during their lifetime. It was already mentioned, women more often, twice as often than men. Depression is the leading cause of disability and premature death in young people and middle-aged people. Untreated depression is associated with worsened medical morbidity and mortality. Roughly 10% of patients who show up in the primary care office meet the criteria for a major depressive disorder. And 30 to 40% of patients with chronic medical illnesses meet the criteria for a major depressive disorder. It is the primary care physicians who are the main prescribers of antidepressants in the United States. But unfortunately, only about 20 to 40% of patients with depression actually improve substantially in the primary care setting over a 6-month period. So we're not very successful in actually treating depression in these patients. Now, if you're a primary care physician and you decide that you want to refer your patients to a psychiatrist, the chances of that patient actually calling and making an appointment is about 50-50. Patients don't really want to come and see us if they don't have to. And also, the majority of primary care physicians actually have difficulty finding mental health referrers or even advice for their patients what to do with their mental health issues. I have a couple of slides just to show you the rates of antidepressant use in the United States. You can see that over the last couple of decades, the rates have increased for both males and females. This is a breakdown based on age and sex. So the middle age and 60 and over are the patients who are prescribed most of the antidepressants or taking most of the antidepressants. And this slide shows you the breakdown of by sex and race. And it was mentioned previously, the disparities of access to healthcare. You can see that non-Hispanic whites are the ones who are mostly prescribed or taking antidepressants prescribed in this country. Is it because the rates of depression are higher? No, it's because they have a higher access to mental health care. And so people who are of Hispanic origin or African Americans, their limited access to mental health care and to treatment is disproportionately lower. There are multiple challenges in diagnosing and treating depression in primary care, not the least of which is the limited amount of time that the physician can spend with the patient, especially if the case is complex and the diagnosis is not easy. Physicians tend to overestimate or underestimate the patient's distress, meaning that we might be too quick to prescribe an antidepressant when actually the patient doesn't need it, or we may actually miss the diagnosis of depression. Now, not all depressed individuals actually spontaneously express emotional symptoms, especially or typically geriatric patients. They will not complain of feeling sad or depressed, but they will come to you with aches and pains. And on the other hand, not all depressive symptoms imply a diagnosable psychiatric disorder. So depression is a symptom. It doesn't necessarily mean that the person has a mental disorder. 75% of patients with depression actually will come to see their primary care provider, but the primary care providers can accurately identify about half of true cases. So they're able to positively diagnose a patient in about 50% of the time. They're better at identifying who does not have clinical depression, and that's good news. So you may say, well, how do we find people who have depression, who may need the treatment? And we know that screening improves the accurate identification of patients with depression in primary care settings, including pregnant and postpartum women. But the U.S. Preventive Service Task Force recommends to screen only in clinical practices that have adequate systems in place to ensure accurate diagnosis, effective treatment, and appropriate follow-up after screening. So think about the places that you work at. Would you be able to start screening people for depression and have all these sort of services and resources available to take care of these patients if you do identify clinical depression? Because if you screen, you need to screen initially, and then you need to screen at regular intervals. And the patients who are at risk that you think about are women, young and middle-aged adults, lower education, unemployed, patients with chronic illness, patients who have other mental health disorders, or who have family history of psychiatric disorders. I'm sorry it's like that, but probably many of you are familiar with the patient health questionnaire, which is self-administered 9-item questionnaire that the patient answers, and it's free to use. Anybody can use it for clinical practice. It comes in English and Spanish, and it's one of the screening instruments that has been validated for identifying depression. The first step in diagnosing depression is that you ask the patient about depressed mood or anhedonia over the past 2 or more weeks. Over the past 2 weeks, have you felt down, depressed, or hopeless, or have you felt a little interest or pleasure in doing things? And the positive response to either of those questions warrants a thorough review of other criteria for major depression, and these are the criteria. Most of you are probably familiar with them. These criteria, 5 out of 9 of these criteria need to be present for at least 2 weeks during the same period of time to make a diagnosis of major depression. Ideally, before you prescribe an antidepressant, you should screen for a history of hypomanic or manic episode, and be vigilant to the risk of suicide. Unfortunately, less than 40% of family physicians ask patients presenting with depression or requesting antidepressants about suicidal ideation. And we know that 40% of adults and even more older adults who visited their primary care provider within a month of committing suicide, 90% of suicidal youth saw their primary care provider within the previous 12 months. So these patients don't necessarily come to us. They see you in your offices. Things not to be missed in depressed patients: suicidal thoughts, homicidal thoughts, any opportunity to reduce access to firearms and medications that can be harmful if taken in large quantities, psychotic symptoms, drug abuse, systemic medical causes of depression, and bipolar disorder. And I'm going to skip, forgive me, I'm going to skip a couple of slides here to get to this, because this is what I want to talk to you about as far as thinking outside of the box and ways that you could improve mental health care and access to mental health care in your settings. So if you're a family physician or a primary care physician, you have a few options probably what you want to do. One, you can decide that you're going to prescribe the antidepressant for the patient. Now, what are the chances that you will see that patient in a few weeks to check in if they're tolerating the medication, if they're starting to respond to medication, if you need to adjust the dose? I think the chances are probably low. That's my guess, right? I've seen many patients who were started on an antidepressant and kept on the low dose without feeling much better. So some of these patients do actually need to see a psychiatrist to optimize their treatment. If you're lucky, you may have a psychiatrist co-located with you in the clinic, or you may partner with somebody in the community that you can refer to. But one of the models that has actually been developed by psychiatrists is the collaborative care model that can be delivered in person or through telemedicine nowadays. And if you think about the sort of the traditional primary care physician-patient relationship. They're the team, right, to get the patient better. But the collaborative care model thinks about a multidisciplinary collaborative team where at the center is the care manager, not to be mistaken with case manager, because this could be a social worker, this could be a nurse practitioner, who helps to manage a cohort of patients who were identified as having depression and in need of treatment. The psychiatrist has a consulting role. They help to guide the treatment, and the treatment is tracked. The patient may be initially screened, and then they're rescreened, and we're tracking how responsive they are to treatment, and do we need to adjust the dose of the medication or refer them to other services to optimize the treatment. The patient may never see the psychiatrist in person who's consulting for this team, but they are getting care better as usual, and multiple randomized controlled trials have shown that this kind of collaborative care is more effective than usual care. Outcomes remain improved for as long as 2 to 5 years out. Collaborative care for depression and chronic illness improves both mental and physical outcomes while saving healthcare costs, including reduced hospitalizations and emergency room services utilization in patients with complex comorbidities. And if you want more information, this program has been developed by the University of Washington. You're welcome to go to that link. And also, Nancy asked me to mention that we had more flyers at our table, but they all got taken. So she will create a link for you that you can access them afterwards. Thank you very much.
Thank you so much. And now I'd like to introduce Dr. Samir Hassamal. Dr. Hassamal has worked in various relevant capacities, including as a director of psychiatry consultation and liaison services, an administrative consultant with LA County Substance Abuse Prevention and Control, and assistant professor of psychiatry at the City of Hope National Medical Center, an NCI designated cancer center. Welcome.
Well, thank you for being here. So I'm Samir Hassamal. I'm one of the psychiatrists here, but I also treat patients who have a history of primarily a prescription opioid use disorder. And today I'm going to be talking to you about a practical approach to identify and manage use, abuse, and dependence in your primary care clinics. So when patients are referred to me, typically, they already have an established diagnosis of a substance use disorder or problematic use of their drug of abuse. However, it's up to you, the primary care providers, to identify these patients, assess them, and refer them to me, because you all are the front line, it's not me. And these are the kind of patients who can frustrate you, perplex you, call you at 4 p.m. because they lost their prescription for Dilaudid or Ativan again. Does this sound all too familiar for some of you here? And so today I'm going to talk about definitions and then talk about epidemiology, screening, brief intervention, and referral to treatment. How many of you here have heard of SBIRT before? Okay, great. So I'm going to spend most of my presentation talking about that. So misuse is synonymous with risky use and hazardous use, and it's a substance use that threatens health and safety. I'll give an example. I get into an argument with my wife, and I take Dilaudid to feel better. Not for pain relief, but to feel better. That doesn't necessarily mean I have an addiction, but I am misusing my substance. So it's important for you to discriminate between the two. An addiction or a substance use disorder, as defined in DSM-5, it's a chronic neurobiological disease that is defined as a problematic pattern of substance use leading to clinically significant impairment or distress manifested by 2 of 11 criteria occurring within a 12-month period. Now that's 2 of 9 criteria if it's a prescription opioid. And the reason why it's 2 of 9 is because of physical dependence, which is tolerance and withdrawal. So let me explain that to you. So physical dependence, it's a normal, homeostatic, adaptive response to drug use. So probably everyone here in this room would develop physical dependence if they took a drug for a long enough time due to changes in neurotransmitters in your brain. And that's manifested by tolerance, which means that you need more of a drug to experience the same effect, and withdrawal, which means that upon drug cessation, you'll experience various autonomic symptoms, such as, for example, when you stop opioids, you experience flu-like symptoms, and when you stop alcohol, you get like the shakes, tremors, and seizures. But that does not mean you're addicted to your substance. That just means you've been taking for a long enough time. So I get referrals from the community, even here at the City of Hope, the big, well, the patient stopped their medication and had withdrawal, now they're addicted to the substance. No, it's not the same thing. It just means that they've been taking for a long enough time. And so that's why with prescription opiate use, it's 2 out of 9, because they removed the physical dependence criteria, which is tolerance and withdrawal, from the criteria if you're taking a prescription opiate, because it's expected that you will have that. So these are the cardinal features of addiction. Each of these 4 criteria have biological correlates and are part of the research domain criteria. So the first one is pronounced craving. Your patients will describe this as hunger for the drug. Continued use despite consequences. Patients will tell you that I'm using the drug even though it's interfering with my life, fighting with my wife, not going to work, I'm using drugs instead of buying groceries. There's also compulsive use. So when patients stop using, they have extreme anguish and loss of control. The patient says, well, I'm only going to drink 2 beers today, but ends up drinking 6. Okay? So if you have 5 minutes with your patient, these are sort of the 4 things you should sort of touch base with them about, and it'll give you a good sense of whether or not they have an addiction, rather than going through the 11 criteria of the DSM-5. So this is the prevalence of substance use by gender. In a nutshell, essentially, most of your patients that you're seeing are using tobacco and or alcohol. I know we focus a lot on prescription drugs, but that's a small percentage of people. Okay? Most people are using tobacco and alcohol. And in terms of the leading causes of preventable death worldwide, tobacco is number 2 and alcohol is number 8. And a lot of the other causes like hypertension, sexually transmitted diseases, obesity, poor diet are related to tobacco and alcohol. And so we tend to forget about that and mostly focus on opioids and benzodiazepines, but we should remember that alcohol and tobacco are leading causes of preventable death worldwide. And these are the complications from substance use, so high blood pressure, cardiovascular disease, psychiatric disorders, depression, anxiety, liver disease, risk for a whole host of cancers, HIV, AIDS, and trauma. And your patients aren't going to come to you and say, hey, doc, I've started to drink more and my blood pressure is getting worse. It's up to you to screen the patients and make that link. And that link can be powerful because you can actually motivate your patient to make change by showing them that there's a link between their substance use and worsening or deterioration of their health condition. So why is universal screening important? Drinking and drug use often go undetected, and it has to do with perception to some degree. A lot of people, when they think of someone who's an addict, they think of someone who's homeless, maybe injecting drugs, a high utilizer of ER service, but that's just a small percentage of patients. You have a lot of patients who are highly functional or using alcohol and drugs. They're going to work, they have families, but they meet criteria for abuse and addiction. So that's why it's important to screen patients, because at face value, it may not always be so clear. And only 1 in 10 patients with a substance use disorder receive treatment. That's kind of appalling. Imagine if I told you 1 in 10 patients with HIV receive treatment. There'd be a huge outcry. And that's because we're not doing enough in terms of screening. And also with screening, we can detect risky use at an early stage and intervene. So clearly, if you intervene early on in the addiction process, you'll get better outcomes. And also to detect current health problems related to the substance use. The patient may have worsening blood pressure, worsening diabetes. You may be prescribing metformin or lisinopril, and it's getting worse, right? Because they're continuing to use substances. And surprisingly, patients actually want to discuss their substance use. This is a study that was done. I'm not going to go through each stage, but essentially they want to talk to you about it, if you use open-ended questions. And so this is why the CDC came up with SBIRT. It's a comprehensive, integrated public health approach to identify and provide treatment for patients at risk or with a substance use disorder. So screening, it's universal screening. It's to quickly assess use and the severity of alcohol, illicit drugs, and prescription drug use, mis or abuse. I'll talk about that a little bit later on. There's brief intervention. This would be like a brief motivational and awareness raising intervention. And then there's referral to treatment. If you don't have enough resources or if they have a substance use disorder, you can refer to treatment. And I'm going to talk about ways that you can refer patients to treatment in your clinic. So pre-screening questions, what you can do is when the patient is waiting in the waiting room, you can ask them, or you can have the LVN or the nurse ask them, have you ever used any tobacco, nicotine products? If they say yes, obviously go ahead and do a full screening. I've seen some studies that say 3 months or 1 year. I just like to keep it general, right? So you can actually have a higher sensitivity and screen more patients, because you don't want to miss patients who are obviously using. Then you can ask a patient on any single occasion, have you had more than 4 drinks containing alcohol, or 3 for women. And then for prescription opioids and illicit drugs, you can ask your patient, have you ever used an illegal drug or used a prescription medication for non-medical reasons? Because of the experience or the feeling it caused, or you could say, or used a prescription medication because of the experience it caused you. And so these are 2 screening questionnaires that you should use in your primary care office. It really takes about 5 to 10 minutes to do. One is the audit and one is the DASC. They're both 10 questions. They take about 5 minutes to do. You can integrate it into your HR. You can integrate it into your tablets. There's even an app now for these 2 screening tools. And you can have the patient complete it while they're waiting, right? Because generally when you go see a doctor, you're waiting about 10 or 20 minutes, sometimes 30 minutes before the doctor sees you. Have the patient complete the screening, collect healthcare data on them, and that's where I think our healthcare system is lacking. We should make use of the time when patients are just waiting to see the doctor. And so these are the risk levels for the audit and the DAST. So what this slide shows is that 78% of the patients that you screen are going to be low risk or no risk. So these patients, there's no intervention, right? You just provide a positive health message. Yes, I know you drink alcohol, but it's within the normal range, and please keep it within that range, for example. 9% will have risky use, and then you'll perform a brief intervention, which is what I'll talk about in the next slide. And about 8% will have harmful use, and in those cases, you want to do brief treatment. And if you're not very resource intensive, refer those patients out. And if someone is dependent or has a use disorder, clearly you want to refer them on, and that's going to be 5%. So only 5% of the patients you screen are going to meet criteria for a substance use disorder, on average. Okay? Obviously, if you're in a high-risk clinic, this number may be a little higher. So this is a flow chart. So you screen your patients using the audit and the DAST. If they're at low risk, you don't do anything, except encourage them and validate their use. If they're at moderate risk, a quick brief intervention. If they're moderate to high risk, brief treatment / brief intervention. And if they're at severe risk or have a use disorder, then you want to refer to specialty treatment. But before you refer them, you obviously want to assess readiness to change. So if a patient is in the pre-contemplative phase, which is probably like 1 to 3 here, and they don't want to change, unfortunately, referring them to treatment is not really going to help them, right? And so you want to elicit the negative consequences of the drug use, express concern, offer support, information, follow up. If they're in the contemplative phase, like 5 to 6 or 7, then you want to heighten that ambivalence. Like, okay, I'm glad you know that you don't want to use your substance, but look at all these things that it's doing for you, and where do you want to be? And offer support and follow-up. Generally, patients who are in the contemplative phase will tell you, I know my drug is bad for me, but I want to make the change in 2 or 3 months. And so you want to sort of heighten that ambivalence so that so you motivate them to do it quicker. Scores that are 8 to 10, these are patients who are in the preparation phase, who say, okay, I'm ready to do it now. With those patients, you want to help them develop an action plan so they can move into the action phase, identify all the resources and instill hope. And so I have 5 seconds to tell you about that. So this is a brief intervention. You can use something called frames. I'll be quick, I have a couple more minutes. Frames is something that you can use in your clinic as a brief intervention. So feedback. So if you have a patient who's at moderate risk, you should provide feedback on the risk for alcohol problems. Yeah, so I see that I did a screening test and it says that you're at a moderate risk for developing a substance use disorder. And you tell the patient that it's up to you to sort of make that change so your diabetes can get better. And then you can give the patient advice about reduction. Well, I think if you stop drinking alcohol, your blood pressure may get better. And then you can provide them with some strategies for change. So what is it that makes you want to drink? Well, doc, it's when I see my friends, when I see the pub, when I'm stressed out. And you tell the patient, well, write a diary when you drink. Avoid that situation with your friends at the pub. Speak to your wife when you have that urge to drink. So that's an example of it, and there's many. Express empathy that, yes, I know it can be difficult for you to stop drinking alcohol, but I have confidence that you can do it. So provide some self-efficacy. And referral to treatment. Referral is recommended when patients meet the diagnostic criteria for a substance use disorder. So strong referral linkages are critical. So if you're going to implement this, make sure you can refer a patient out, because you don't want to tell a patient, well, you have a substance use disorder addiction, but I don't know where to send you now. The good thing is that Los Angeles County recently launched the drug Medi-Cal waiver. So it provides an array of services for patients who have a substance use disorder. So one thing you can do is you can have your patients, or if you have a social worker or an LVN, they can call something called the SASH, which is the Substance Abuse Service Helpline. This is their number. The operator on the phone will go over something called the ASAM, and it'll help place the patient into the appropriate level of care and schedule an appointment with an appropriate treatment center. So call this number if you have a medical patient who you think has a substance use disorder. And if you've already established that they have a substance use disorder, you can use something called the SBAT, the Service and Bed Availability Tool. This is a link here. You go on there, you type in the sort of service you think your patient needs, and they'll give you a list of facilities that have open beds. And I just wanted to talk to you about some of the great work that we're doing here. We have a smoking cessation support group. It's every Monday at 3 p.m. And we have a table over there. And we have a very unique staff here for the smoking cessation program. We have Dr. Type, who I believe is here in the audience. He's a pulmonologist. We have someone from the ICU. There's me, an addiction psychiatrist. We have a nurse who specializes, a nurse practitioner who specializes in smoking cessation, and we have a great coordinator. So please feel free to refer your patients who are smoking to us. This is the contact information. And I guess questions will have to. Thanks.
Yeah. All right, and now we're going to have all of our panelists join us on the stage. So please come up and take a seat. Great. All right, well, first of all, I want to thank all of you so much for sharing your thoughts. And again, I mean, there were some really just incredible data points that I think many of us in the room weren't aware of as we were coming into this conversation this morning. One of the things that really struck me in particular was the statistic that you presented, Nancy, that 11% of psychologists, MFTs, counselors will be retired. We'll have less of them by 2028. In thinking about that and some of the statistics that Dr. Salman showed us, that 80% of primary care providers are already sort of, holding the burden of addressing a lot of mental illness in their practice, and knowing that they're going to have to start absorbing a lot more. What are some of the things that we can do right now to start, readying ourselves for this, and how do we equip ourselves as providers? I'm asking all of you, yeah.
So from a community perspective, I'm thinking that we need to really start like we do in most ROP programs or high schools. We talk a lot about physical health care, right? We don't, I think, talk enough about mental health. I'll throw dentistry in there too, because they're the other ones that get lost in the whole shuffle of it all. But I think if we start being proactive in removing the stigma and the fear and the barrier, and really promoting this as an enriching field that our community needs and desires, and developing supportive programs around that, not only through the college level, but starting earlier, that I think that we can start reversing that trend.
Well, as I'm listening to it, I'm thinking about all the ills of our society that are contributing to the rates of mental illness and the disparity of access to healthcare. And at first I wanted to say, well, there are new forms of delivering psychiatric services and also psychological services through telemedicine, telepsychiatry, for example, or the collaborative care model that I mentioned. There are different variations of that, where you could have the psychiatric expertise from somebody who's remotely guiding you in taking care of your patients. But I really think that our efforts cannot be focused only on treatment of these disorders, but also on prevention. How do we create healthier neighborhoods and societies where people can feel supported? And I think that that's a broader question that cannot be answered only by psychiatrists or psychologists, but the whole society. And I think it's upon us to seek answers to that, because it's disturbing to see that the rates of antidepressant medications have been elevated or increasing. But also, you may know that the rates of suicide in our country have increased in the last few years. And nobody really knows exactly the answers to that. Why is that happening? There are more questions than answers, I'm afraid.
Just thinking about that a little bit, and then looking at the data across LA County and seeing, dramatic disparities across communities and different spas. Certainly a part of that is, social determinants of health, but another part of that is really access to providers and really, sort of focusing resources in particular communities. What are some of the ways that you think we might be able to address that? And how can we come together collectively as community organizations and healthcare providers to really address it from that angle?
Okay, great. I think one thing we can do is expand the scope of practice. So one thing we can do is, in mental health, we have a lot of limitations. You have UMDs, we have PsyDs, we have MPHs, we have psychologists, social workers, a whole array of different mental health care providers. And I think we need to expand the scope of practice and have more professionals that weren't at one point doing psychiatric care, using a lot of LPHAs, but also licensed eligible LPHAs. Doing more work with less supervision to some degree. I think that's the only way we can really increase the capacity.
Great, thank you. I'd like to take a couple of questions, and why don't we start over here, Ms. If you'd like to.
I had a question for Dr. Saltzman and for you in the middle. You were talking about, and maybe I misunderstood, Dr. Zora, that you were saying that the psychiatrist doesn't see the patient, but the other people do, the physician's assistant and all that. Do you mean they don't meet with them at all? Because it's been my examples, or in SPA 6 and SPA 7 especially, that people get misdiagnosed and everything if they're not at least seen by a psychiatrist at least one time, or even the PsyD. So were you saying that you don't actually see the patient?
In the collaborative care model?
Yeah.
Not necessarily. I mean, it depends on the place where they decide to implement it, but the idea is that the patient is identified, let's say through the patient health questionnaire, as having depression, and the care manager is trained to sort of screen for suicidality and bipolar disorder, and the psychiatrist advises the primary care physician in prescribing an antidepressant and adjusting the treatment. So it's really a consultative role for a psychiatrist who may not see the patient directly. If there are any concerns that this could be a complex case, then the patient may be referred to a psychiatrist, either the consulting one or somebody else who can diagnose a more serious mental health issue.
Because like I told you, I specialize in grief and loss, and I've had some horrendous cases where the person got misdiagnosed. Or I had a case where a mother of 5 had a 2-month-old baby, and she was suffering from postpartum depression. She went to the emergency room, and she never saw a psychiatrist. They literally laughed at her and said, under DMH, she couldn't get a visit for a month or 2, and she went home and killed herself. And I know that had she been in a different SPA, because this was SPA 6, she would have gotten different treatment, especially considering she'd had all these children and never had this problem before. So my concern is that if they don't see the psychiatrist or the PsyD, there's not enough experience maybe or training for them to sometimes deal with some of these kind of difficult situations, especially in certain areas. So that was my question and my response.
So, and the good news is we're going to have a few presenters from DMH here. And now that they've heard your comment, they're going to be able to address that and provide you with the information that you need to help us sort of bind those gaps.
Yeah, because with a lot of my clients, it's taking 2 or 3 months even to see a therapist under DMH. It's gotten really, really bad.
Thank you. Take a question over here on the right-hand side.
Hi, good morning. So I'm just wondering, as far as the health disparities and access to care, I was also wondering the role that stigma plays in accessing the treatment for underserved communities, especially for medication support. So I don't know if you can comment about that, because I think that also plays a role. And then the other thing was for Dr. Hassamal. I work in a federally qualified healthcare center in integrating behavioral health and primary care, and we're reviewing our expert screening tools. And I appreciate you recommend, the audit that is used. I'm just wondering if you can comment on the use of the CAGE, which is it's more brief, but what your thoughts are about that screening tool. Thanks.
As far as the stigma of treatment, it's there, it's out there, and some of it is culturally determined. We see it in our patients quite often, that either first of all, they don't want to come see a psychiatrist, or they're afraid to be on a psychiatric medications. They'll say they don't want the family to know that they're taking any psychiatric medication. So it's a process, and I think this is an ongoing process of destigmatizing mental health, and it's upon all of us who are out there to help destigmatize and talk about it really matter-of-factly, even within the primary care offices, as something that anybody can deal with or be faced with. But here at City of Hope, we're really lucky that our colleagues who are non-psychiatrists don't have a problem, suggesting to the patient that they want their psychiatry colleague to come and see them and help them out. So it's an ongoing battle, so to speak.
Well, thank you. Unfortunately, we do have to wrap up this session, so I want to thank all of you for your time and your incredible presentations. Okay, sure.
Okay, so just to get back to your question about CAGE. So CAGE is cut down, you get annoyed, you feel guilty, an eye opener regarding alcohol and other drugs. I think the CAGE, it's a great screening questionnaire, but I think it can miss a lot of patients who are using alcohol. The audit is richer, and it asks a lot of questions, especially questions like related to social distress from your drinking, because you can see with the CAGE, do you feel like you need to cut down? Well, no, I'm always drinking. Do you get annoyed when you drink? No, in fact, I feel good. Yeah, maybe they have an eye opener when they drink, and maybe I feel some guilt, but that's 2 out of 4. And what do you really do with that? Whereas with the audit, it'll stratify. It'll give you like low risk, medium risk, or high risk, or if you have a use disorder. So I prefer that. I feel like it's a little cleaner, in my opinion, if that's helpful.
All right, thank you all so much. And again, all of our panelists will be available during our break. Thank you. You can just leave it on the chair. So again, all of our panelists will be available during the break for any further questions. And I know that many of your questions will also be addressed during our upcoming panel sessions. So now I would like to move on to our next session, which is the intersections of policy, law, and mental health. As the state and the nation's systems of healthcare, social services, civil and criminal justice continue to change, we know that we need sound laws and policies in place that support access to mental health resources. With a rapidly changing environment, how do providers know what resources are available to them to support their patients? And what is a provider's role in interpreting law and policy around mental health? With us today, we have Kayleen Gilbert, who is a mental health clinical program manager for the Prevention Bureau with the LA County Department of Mental Health. During her tenure with the Department of Mental Health as a clinician, Ms. Gilbert has provided mental health services for adults in the San Gabriel Valley. As an administrator, she has overseen adult services ranging from traditional outpatients to intensive service programs across LA County. Great, welcome, Kayleen.
Good morning. It is really, I think it's exciting to be here, and I'm really so pleased that City of Hope is taking the time to do this, because access to care and quality care is certainly one of our passions with the Department of Mental Health. And for me, on a personal note, actually, it's important for me to be here because some time ago, City of Hope actually treated one of my family members, and I was here quite a lot. And I felt like the care was so compassionate and so supportive. I'm really grateful for the opportunity to give back and to partner around mental health and mental health needs. So I'm going to start. Is there a click? How does this work? Sorry, excuse me. There we go. Thank you. There's a hidden keyboard down here. So who are we? With the Department of Mental Health, we are the LA County Department of Mental Health. We serve all folks from the Antelope Valley down to the South Bay, from the San Gabriel Valley to the west side. We have a broad array of provider services ranging from our outpatient services, inpatient services. We have a network of contracted providers and a network of directly operated providers for adults, children, transition age youth, and we have specialty services for older adults. So previously we talked a little bit about the spas were referenced before. So I'm going to throw the map up here. It's a little easier sometimes to find our services if you're familiar with the spas or the major regions in LA County. So we serve the Antelope Valley, San Fernando, San Gabriel, Metro Los Angeles, West Los Angeles, South Los Angeles, East, and the South Bay. So for the Department of Mental Health, we're the largest county-based public mental health system in the nation. As I mentioned, we have a number of directly operated sites. These are clinics that are operated by the county, where we have county employees, social workers, and psychiatrists working. We have a number of contracted agencies. We have about 138 legal entities across LA. We are a pretty big network of providers. And then we also have a number of co-located sites, and that's our effort to make better connections in the community. So for example, we have clinicians that are co-located in Department of Children and Family Services offices. We have clinicians that are co-located in health offices or healthcare centers or health sites. So we really try to make every effort to make our services available and ensure there are bridges to services where we know or we believe they're needed the most. So when it comes, we talked a little bit earlier, I've heard some notes about cultural competency, and at the department we talk a lot about cultural humility. Our services, we know within LA County, we're quite diverse. So we have our services that are provided in all the threshold languages, and if you're not familiar with what a threshold language is, among the Medi-Cal population, once you hit about 5% of the Medi-Cal population that speaks a certain language, we identify it as a threshold language, and we need to provide materials and services in that language. So we have services in Spanish, Chinese, Armenian, Farsi, Cambodian, Vietnamese, Korean, Russian, Tagalog, and Arabic. And when I talk a little bit later about how to access those services, you should be able to get language on our access line if you have a language of need. We have interpreters available there too. We also offer services in American Sign Language. Another way in which we really try to make that connection with the community and with our clients is by employing staff with lived experience. And that means people who have had experience with mental health, who have received services in the system, and can connect better with our client population. They're able to offer something oftentimes that our clinicians can't, and that connectedness, and to help guide folks through the services. So they have been an important part of our mental health treatment teams, as well as the parent partners. And those tend to be parents who have had children or youth who have gone through the system too, and they play a really significant role in supporting parents in the community with children who have mental health needs. We've created networks to increase cultural access. We have a number of specialty groups in the department where we bring stakeholders together to talk about access to care for specialty populations or ethnic groups. Because really with every culture, of course, there's a little bit of a different approach, and we really want to make sure that we're making those connections. And then we have multilingual, multicultural staff development. So it's not just about language, and we know this, and that's when we want to talk about cultural humility and really understanding and taking the time to get to know the person in front of you. You may speak the same language, but may not mean have the same experience, or you may even come from the same place. But it's always important to sit back and question and work with the person in front of you and really understand what those needs are. So that's an important principle for the department. So these are some of our basic principles. We really, in the department, talk a lot about recovery and resilience. How many folks here have heard of recovery, the recovery movement in mental health? Wow. So recovery is really about identifying not just the symptoms that need to be treated, but I think the identity of the person and who they want to be and where they want to be. So when it comes to mental health, when I started some 18, 20 years ago, we were a lot about symptom management, and that's something that we still do. That's still pretty important, but the person sitting in front of you ideally has some goals and interests, and really it's about quality of life and helping them meet those needs. So every person sitting in front of us is capable of recovery, is capable of meeting their own personal goals. And symptom reduction is part of that, but it shouldn't be the last part of treatment. It shouldn't be the end. So we really make an effort to work with folks around their hopes and dreams and make sure that we do the best we can to partner with them and help them find that path. So what is mental health? We've talked a lot about depression this morning, but mental health includes our emotional, our psychological, and our social well-being. It affects how we think, feel, and act. It determines how we handle stress, how we relate to others, and how we make our choices. And when your mental health is compromised, what we see is a pattern of mild to severe disturbances in thoughts and behavior, resulting in difficulties with coping of life's ordinary needs and demands. It's often related to excessive stress due to a particular situation or series of events. It could be somebody dealing with a major illness or somebody dealing with a loss, for example. In some cases, mental health is related to genetic factors or biochemical imbalances that can compromise somebody's health, and that's when we start to talk about schizophrenia, bipolar disorder, and even depression and anxiety can be related to chemical imbalances. But we know that not only are treatments, medication treatments are not the only effective treatments. Oftentimes, particularly for depression and for anxiety, therapy is often very, very effective. And then we can talk about trauma, toxic stress, and lived experiences, which are a big part of mental health and mental health needs. This is another new area for us in the Department of Mental Health and in the mental health field as we start to talk about trauma and the impacts of trauma and its impacts on overall health and well-being. So I'm going to ask another question. How many folks here are familiar with the ACEs study? Has anybody heard of ACEs? More hands. Great. This is the Adverse Childhood Experiences study that was completed by Kaiser back in the 90s. And what they did is they took a look at adults that they were serving and questioned them around their experiences in childhood. And they looked for adverse childhood experiences. And examples of that would be like abuse, drugs in the home, loss of a parent. And what they found was the greater number of adverse experiences, the greater the likelihood of poor health outcomes. Diabetes, high cholesterol, heart disease, but that wasn't all. They also identified that the greater the number of ACEs, the greater the likelihood of depression, the greater the likelihood of anxiety. So we know now that those experiences early on can impact mental health across the lifespan. So that makes it now our business to consider how can we get involved, how do we work with prevention and prevention services to try to reduce trauma, to mitigate the impacts of trauma, and to build protective factors in the community and within the individual. So that is a new and emerging piece for us. And fortunately here in California, we have something called the Mental Health Services Act, which is that millionaire tax that was passed about 14 years ago. Part of that funding that comes to us from the state is specifically dedicated to prevention and early intervention. So it's a whole new area in which we can begin to make an impact in the community. So examples of mental health symptoms in young children, you might see changes or irregularities in sleep habits, which include nightmares, changes or irregularities in eating habits, or not meeting their developmental milestones. Mental health symptoms in children could look like changes in school performance, changes in sleeping or eating habits, excessive worry, anxiety, hyperactivity. You can also see disruptions in social relationships. For adults, you may see confused thinking, prolonged depression or sadness or irritability, feelings of extreme highs or lows, excessive fears, worries, and anxieties, social withdrawals, and dramatic changes in eating or sleeping habits. So our services, we serve a variety of age groups. We specifically serve the Medi-Cal population, those with Medi-Cal, those with no insurance, or we serve folks maybe who are working on a sliding scale fee. If you have private insurance, one should really go through their private health provider. If services or if the needs are mild to moderate and you have a Medi-Cal managed care plan, they have a full network of services available with psychiatry and mental health through primary care oftentimes, but they also offer therapy services through primary care. Services provided. So we've talked about individual therapy, family, group, medication. We offer case management services, which is all those linkages to anything from housing and other needs, substance abuse services. This is, you should have the link to this document in your, in the email that was sent. But this is our full continuum of care and services that range from prevention all the way to intensive services. And how do you determine if there's a need? Well, you would want to engage with somebody, ask those questions, look for some of the symptoms that we've identified and talked about. And if there's a need, help somebody, you can either make a call for them to help identify where those services might be available to them or where their local clinic is, or encourage them to make the call themselves. And the best way to reach our services is through the DMH County website, which is dmh.lacounty.gov, our access hotline, which is the 1-800 number here, or the service area navigators. And in your packet, you have a sheet that lists not only our website and our phone number, but the service area navigators. That access hotline is 24/7, and it's the hotline that you're going to use to either look for services locally, or you can actually call it if there's a crisis or an emergency. If somebody is expressing suicidal thoughts or is in need of urgent or emergency services, this would be the number you call, and they should be able to get access to you pretty quickly. Or if needed, if it is an emergency, a team out to you to assess for further needs. This is our website, English and Spanish. So this would be down here at the bottom. You can see, you can look for, you can enter in your zip code and you can identify where all of the local clinics are. This is a pretty good tool for finding services in your community. Mention the access hotline. I know I'm running out of time here. So I wanted to talk for just a sec though about what you can do. We talked a little bit earlier about the role that all of you play in addressing mental health and helping people access care. When I talk about prevention, one of the things we want to do is help raise the capacity of people in the community to identify mental health, to be able to talk to somebody in distress and to make those referrals. So what we have offered and what we're still offering is the mental health first aid training. We offer mental health first aid training for adults, for youth, and for older adults. And this training really does help. It's for non-mental health professionals, helps you to identify when somebody's in distress, gives you some tools for how to work with them, how to talk with them, and how to make those referrals for care. We also offer suicide prevention trainings. So as part of this forum here, we're going to put together a day and time for a training. So we have a sign-up sheet for folks who might be interested in mental health first aid training or in suicide prevention training. We really want to raise awareness out there in the community. If you are part of a larger agency, we can come to you. We can train whole staff. And this goes to anything from from healthcare agencies, if you're from a faith-based organization, broad community, we want to be here to provide that training in the community. So you can also request training by contacting our suicide prevention at dmh.lacounty.gov, our website. But we also have flyers over there if folks are interested in seeing that menu of trainings. So I'm going to turn it over to Evelyn.
Thank you so much. Thank you. Please do take advantage of the resources that the county does have here today. They do have a table just right over here with a lot of really amazing information. So now I would like to introduce Evelyn Lemus with the East San Gabriel Valley Mental Health Center in the Health Neighborhood. Evelyn is a licensed clinical social worker and joined the LA County Department of Mental Health in 2011 after graduating with her master's degree in social work from California State University of Los Angeles. For the past 2 years, Evelyn has been responsible for overseeing the health neighborhoods and is also the faith-based liaison for the San Gabriel Valley region. Welcome, Evelyn.
Good morning, everybody. So I want to thank Nancy for inviting me today to speak. So again, my name is Evelyn Lemus. I'm with the Department of Mental Health, and I've been spearheading the health neighborhood the past 2 years, and I'm also the faith-based liaison. So today I'm going to speak a little bit about the services, specifically to Service Area 3. I know Kayleen spoke about the broader services through LA County, but today I'm going to speak more to the services that we offer here in the San Gabriel Valley area, and also about the health neighborhoods, which is a collaborative efforts that we have here in the area. So right here, you're going to see a map of San Gabriel Valley. As you know, the county is divided into SPAs, service planning areas. So here you're going to see a map of Service Area 3, which is a pretty big geographical area. It goes all the way from Pomona to Pasadena to, I believe, Commerce and also Diamond Bar. So it's a pretty large area. So in Service Area 3, we have 2 directly operated clinics. We have the Arcadia Mental Health Center, and now as of a year and a half ago, we have the East San Gabriel Valley Mental Health Center. We have the SB 82 mobile triage team. For those of you who are not familiar with the SB 82 mobile triage team, they're our team that goes out to the community to really engage the homeless population. We have some brochures at the table, so you can contact them. There's a fax number and also a phone number you can call, let them know that there's an individual who is homeless and in need of some services. The team will go out there, they'll respond within a couple days, try to engage the client and really get them connected to services. It may not be mental health services right away, but it could be maybe getting a driver's license, getting connected with GR. And they go out there time after time to really try to engage the client, build that rapport, in hopes of getting them connected to whatever services that they need. And also the PMRT team, they're actually located in our East San Gabriel Valley clinic. So this is the number that Kayleen spoke of, the 1-800 number. So in the event of a crisis emergency, you can call that number. It's 24/7. They respond to any calls. They identify if the client needs to be hospitalized, and they'll arrange the hospitalization. We also have the MET team, so now we've really contracted with a lot of the police departments and the sheriff's departments, and now there's a clinician and also an officer or deputy that will go out to the community in event of a crisis, and if it's identified to be a mental health situation, they will also do similar work of the PMRT. They will identify if this client needs to be hospitalized. So it's been a nice collaborative, and alongside of that, we have the HALO team that Mickey spoke of earlier, where the city of Covina, West Covina, Azusa, and Glendora have teamed up together, and they now have a clinician once a month, or 1 week out of the month with our DMH SBD2 team, and they go out to the community. So any calls that they get related to homelessness or potentially be mental health related, they go and try to engage the clients and provide them with resources. We also have the specialized foster care. So within DCFS, they're co-located. They have a clinician that's there. If the caseworker from DCFS identifies that this youth, this child needs to be seen by DMH, get them an intake to see if they need to get specialized services, they will connect it with them. And then we have an office in Pomona, Glendora, Pasadena, Almani, and Covina. And then we also have other services. And we have we have 2 directly operated clinics, but we also contract within other agencies. So we have over 100 provider sites, 18 legal entity providers under Service Area 3. So a lot of our children's services are contracted providers. We also have group homes, variety of sites, including clinics, schools, and primary care facilities. So just a little bit about the Arcadia Mental Health Clinic. They do triage, general adult outpatient services, medication support, dual diagnosis services, case management, individual and group therapy using EBPs, older adults and adult field capable services, also wellness services. And the services are very similar to, at the East San Gabriel Valley site, but there they do offer the SB82 and also the FSP, which is a full service partnership. So these are clients who had been identified as more acute and needing more support. So they have a team that will have a clinician and they will go meet with the client, whether it be at the home, at the school, because these are clients that, because of their mental illness, maybe they can't make it to the clinic. So they will go out to the field and respond to these clients. And just like our directly operated clinics, our contracted agencies provide a lot of the same services, medication and support services, individual and family therapy, crisis intervention, and outreach. And now I'm going to speak to a little bit about the health neighborhoods. Has anybody familiar with the health neighborhoods or has heard of the health? I know I see a few familiar faces, so thank you. So the health neighborhood, in 2014, that's when the strategic plan began. So there was an office at headquarters where they sat down and said, okay, we really need to, it was about collaboration, bringing providers together so we can streamline the referral process of clients. So in 2014, they went out to all the service areas and wanted to identify in each service area, what is the city that is underserved and really needs this collaborative. So in Service Area 3, they identified the city of Almani as being a city that was really underserved. So that's where the first health neighborhood started in this spa. But every service area now has at least one, some of them have 3 health neighborhoods. So the health neighborhood brings together health, mental health, substance use disorder providers, and community at large to establish and enhance collaborative relationships. Providers come together with the vital input from the community to enhance the health and well-being of the neighborhood residents. So the emphasis on that is really the health and the well-being of the residents of that identified health neighborhood. Every city is different, every spa is different, so the needs are very different. So that's one thing that we really look into when we're working together with our partners is what are the needs in our specific health neighborhood. And right now at the Almani, we're really working together, maybe doing some sort of needs assessment to see, okay, we've been in existence for a little over 2 years. What are the needs now? Because maybe they have changed from the past 2 years. So that's something that we're going to try to work through and see how we can maybe identify some of the top 2-3 needs. And the health neighborhoods, they came together based off of 2 models. One being the community change model, which the goal is really to achieve community health and wellness, address social determinants of health, community-driven focus on policy and system change. And again, here I want to emphasize community-driven. Even though it was spearheaded by the Department of Mental Health, it's really about community and bringing providers together and really getting their input as to what are the needs that you're identifying in your clinic, in your community. Also, service delivery model. Really, it's to improve the access through integrated mental health, substance use, and public health services for all age groups. Improve quality of services, improve coordination of care, contain costs through effective communication among providers. And then in looking at these two models, they really put them together, and that's how the health neighborhoods, that is the essence of the health neighborhoods, the goals and the mission of the health neighborhoods. And here you're gonna see the framework of the health neighborhood. I know you can't really see a lot of the writing, but in the middle, you'll see the clients, right? The participant, the consumer. And then you'll see mental health services, public health, and health services. So those are the three core organizations that were identified as vital input when putting together the health neighborhoods, but also the other, right? The social services, the faith-based communities, the urgent cares, the regional centers, the schools, the police departments, because when we're meeting with the client, it's about treating the whole person. It's not about the client's gonna come in just for mental health services. 99% of the time, they're gonna have other needs, and it's about really identifying those needs. And sometimes we're not equipped to assist with those needs, but having those relationships with the community and knowing who to refer to makes it a lot easier when referring to our clients. And when everybody's invited to the health neighborhoods meetings, and whoever attends the meeting, this is what they commit to work with each other, parties to outline their right of services and support provided, exchange information between providers to the extent permitted by law, because of course we have to be mindful of HIPAA, develop agreed upon methods of communication between participants. And this can vary depending on each health neighborhood. At the El Monte Health Neighborhood, we have created a directory. So all the participants who are there, who want to be part of this directory, we have a direct contact person. So it's just not the 800 number that you would get or just the general number, but it's an actual person, a contact phone number or an email that another provider can contact directly. Again, to streamline the process of referring a client to that specific agency. And we actually have also developed a website, and anybody can check it out. It's elmontehealthneighborhood.com, and it's a website that's open to anybody, the community members, and also the providers. But we also have a separate portal within the website for the providers that they can access themselves, because they will have direct contact information to the other providers. Also refer and to coordinate care with partnering agencies and respond so the outcomes are clear, consistent, and timely. Identify key contacts with each participating agency for both urgent follow-up and problem resolution. Again, that goes back to the website and also the directory that has been developed. And currently, when we first started, when the health neighborhoods first started, there was only 8. As of right now, we have a total of 13. In the St. Gabriel Valley, we started with the El Monte Health Neighborhood, and now as of October of last year, we also had the East St. Gabriel Valley Health Neighborhood, so we have 2. So the El Monte one has been in existence since 2015. The East St. Gabriel Valley has been in existence since October 2017. At the El Monte Health Neighborhood, we have about 39 providers that attend at any given time, and it varies from mental health providers, primary care providers, substance use disorder services, and other providers like the El Monte Library is there, LASA. We have sometimes the faith organizations are there. And at the East St. Gabriel Valley, we have about 35 providers. And again, it has mental health, primary care, substance use, and other community at large. And when developing the East St. Gabriel Valley Health Neighborhood, because the HALO was already in existence, which covers the city of Azusa, Covina, Glendora, and West Covina, was a better way to not maybe collaborate with them and take on the East St. Gabriel Valley and utilize the boundaries of those 4 cities. And the HALO team is often at our meetings, and they're often connecting with other providers as they're serving the homeless population. And earlier we talked a little bit, Kayleen brought up the navigators within each service area. So I just want to highlight the navigators in service area 3. So I know sometimes the system it's a huge system, so it's a little intimidating as to how do we navigate it, who do we contact to connect somebody. So for DMH, these are our navigators. And I just want to highlight the sheet that Kayleen mentioned. It's in the packet. So here you're going to see all the navigators for all the service area. While you can contact that 1-800 number or contact the clinic directly, these are also people who can assist you in navigating the system so it's not so complicated. And these are Vanessa's for the children, for the adolescents or the adults. If they don't answer, you can always leave a message and they'll call you back. And just wanted to also just show you, this is the website for the El Monte Health Neighborhood. We're working towards hopefully developing one for the East San Gabriel Valley. So also in the El Monte Health Neighborhood, we're gonna do what we're gonna call the El Monte Health Neighborhood Tour, where we're really gonna go out to the community and really promote the website and our agency so that the community, because now all the providers have really built a strong collaborative, but we really want the community to know that this is something that they can utilize. They can go into this website, they can, if they're searching for a mental health clinic, they can go in there and get a phone number. So I invite anybody who's interested in being part of the health neighborhoods, maybe attending a meeting, feel free to contact me. This is my contact information. You feel free to call me or email me. For the El Monte Health Neighborhood, we meet on the 4th Tuesday of every month in El Monte. And for the East San Gabriel Valley, we meet on the 2nd Wednesday of every month in the city of Covina. So that's it. Thank you.
All right, thank you so much, Evelyn. And now we would love to take a few questions from the audience. So if you do have questions, please feel free to line up at the microphones on either side of the room.
Good morning. I'm Barbara Dickerson with the Office of Congresswoman Napolitano. This seems like a good section to talk about policy and laws. So the Congresswoman has a law currently before the House to refund or a loan repayment for those entering the mental health professions. So please be aware of that. And if you're not in District 32, her district, please let your congressperson know that you are in support of this, because that goes back to address the earlier question of how do we encourage and replenish those positions that are going to be vacated by retirees. And then the other piece is that the Baldwin Park School District, in collaboration with NAMI, who's here today, also has a model that's operating to encourage high school students to become aware of professions within the mental health career field. So I think that is a model that some of you might want to look at. As to the scope of care that was mentioned earlier, there's Dr. Ed Hernandez has a bill before the Senate on psychiatric nurse practitioners expanding their care of scope of care, so that gives one more voice in this mental health provider sector. So thank you.
Thank you very much.
All right, so my name is Jovita Murillo. I'm a doctoral student in public health at Claremont Graduate University, but I actually come from SPA 6. I grew up and I was raised in SPA 6. Now, one of the things that I constantly see, especially now that that I'm in public health and in academia and research, is that this connection between community and what we health professionals think is appropriate for this community, right? I still think that there's a huge disconnection, right? Especially in Los Angeles County. Unfortunately, I'm learning about San Gabriel Valley and I'm learning about this side of town, but I know that at least for Los Angeles, I feel that, there's a huge need. There's not enough providers. And so we need to have a better connection. We need to have something in between, right? So I feel that we need to empower the community, and we need to go into the community, maybe even provide basic education on mental health, right? And empower the community so that the community can empower other people within their community. And I think these models are desperately needed because, unfortunately, a person that has suicidal thoughts cannot wait 3 months to be seen by DHS.
And so, you know, between, again, what we think as health professionals, because now I have to put myself in this field, you know, regardless of where I grew up in South Los Angeles, now I have to look at it from both perspectives, not just as a community member, but in my passion, my love, and my everything is in my community, but as a health professional now. And this disconnection I constantly see. And I think that within this, you know, stigma is embedded. And I think, you know, maybe we need to even bring it down to even another level where we need to start getting the schools involved, right? I mean, maybe we need to go out to the schools and start talking about, you know, addressing stigma, right? But I feel like if we're going to address stigma, we need to start with the community again. We need to empower the community, even if that means teaching them the basic mental health tools. My background is in social work. Like Evelyn, right? So I just wanted to bring this up.
So first, thank you for the comments.
Thank you.
And I think it's very poignant and really timely in terms of the work we're doing right now, because I would agree we really have a lot of work to do to make connections to the community and make sure our services are accessible. And I want to tie this back to the comments that we heard a little bit earlier about that tragic outcome, which we should never, ever see again. That right now, some of the work that we need to do is, we need to be in the schools and doing more education around mental health and raising awareness. We need to be in the healthcare settings and raising awareness about the importance of mental health and making those connections and helping the healthcare community to take this seriously. And I think this forum, I think that I understand that to be the purpose of this particular forum, so more of that. The department right now is looking more into expanding our work around prevention. And that's where I think we can now open up our resources to do more of that work, to educate the community, educate healthcare providers, educate faith-based providers around the importance of mental health and help them to access care. We can use some of those prevention dollars to expand some of our capacity and make sure there's more accessibility. That we know, there's a lot of need, and capacity has, I think we're working to do better to ensure that those waiting lists are not there. And in fact, right now, the expectation is that somebody is seen within 10 days. So the department is now obligated to make that happen and to make that work. So that's a change that's in progress now, so that we don't see any of those kinds of waits, and particularly helping educate the community to know that and folks and individuals to respond to crises. And if and when there is a crisis, that the 24/7 hotline number, you can get somebody out there. You should be able to get into a clinic site right away if you're able to, but you need to know where that is. You need to be able to express that concern. So we're doing a lot of work right now around educating communities. That's part of what the Health Neighborhood Connection is and why we're trying to reach out to the broader community. And we're partnering right now with a number of other county departments, such as the Department of Public Health. Particularly in Service Area 6, there's the Trauma Prevention Initiative, where they're doing a lot of grassroots community-based work, and we're partnering with them to bring mental health and mental health awareness in. We're looking for some of these other opportunities. Parks After Dark, I don't know if folks have heard of that, and it's another SPA 6 initiative where they're going into parks at night in high-risk communities, and we're bringing, and it's a number of providers that are in there and creating resources and safe spaces for families, but we're also wanting to bring in mental health and mental health awareness. And so looking for those out of our clinic opportunities to make those connections. And it's a lot of work. I think we've got a long ways to go, but I would agree that, I think it's really important work now. As much as the direct service that we're able to deliver, I think helping people understand mental health, reducing the stigma around mental health, making those connections in the community is just as important. So, and I'm just gonna,
Hello, okay. Along the lines of, empowering the community, we now in Service Area 3 have the promotoras. So these are individuals who have a passion for mental health or who have lived experience or maybe have a child, and they go out to the community and really try to connect with them and educate them on mental health to really remove that stigma, surrounding mental health. And they have free trainings. So anybody who's interested in those trainings, connect with me and I will connect you with the liaison because they're really passionate about this work and they have trainings both in Spanish and English. And this is something that just started in Service Area 3 about a month ago. The initiative started in Service Area 3, that was a pilot, but now they're hoping to really bring it to all the service area. Again, it's about prevention and really about empowering the community.
Should note the Promotores program is countywide now. Okay. So you're in Service Area 3, but I think they're building at least 20 Promotores in each community to be available for community outreach and presentations, education support, and really doing the work of trying to destigmatize mental health.
That's amazing. Thank you both for your insights on that. And just to add from the community clinic perspective, we're often, the first point of contact and oftentimes the only source of care for so many of the patients that we serve. So it's really incredible to have these opportunities to partner with you and access resources from the county. So thank you for that. I would like to take some questions from this side of the room. We are a little bit short on time, so if you could just please make your comments as brief as possible so we can make sure that everyone is heard, and then we'll take a quick break.
Super, great. I talk really fast, so that's great.
Awesome.
Thank you for putting this together. And thank you for all being here and sharing. I feel like it's Christmas. I am like so overjoyed today. My name is Christine. I'm an Air Force retiree, and I'm with US Vets, and I have a new program called Women Vets on Point. We have a website that's directly connecting women veterans to mental health. So thank you. I feel I'm going to be better able to support my community, but I'd also like to engage how I can get in the conversation in the neighborhoods and to remember, women are serving and we have served forever and we often get overlooked. And we tend to be a population that's very, very lacking in trust, and we don't come forward and we don't ask for mental health, even to those that have previously served. So I have some flyers, cards, and I'd love to get your cards for that as well. And just to share, on the second Wednesday of every month, right now at the endowment at 9 o'clock, the LA County Veterans Collaborative gets together. So it's about 200 community partners that talk about veterans' needs. And the Women Vet Working Group meets actually at 9 o'clock. So you're all invited to attend that too. Thank you.
Thank you.
Good morning, Elisa Jimenez. I'm the director for California Mental Health Connection. I have to say my age a little bit, 30 years on the field. So I wanted to really congratulate you because I think that this effort of the collaborative neighborhood is an amazing, and you guys need to meet this woman up there. I'm not saying it because they're here, but I'm saying it because this is the type of professionals that we need. So in the past, because I have two PhDs, one from Mexico, one from the United States, it's such the link between being a professional and the community. So that gives you a whole entire side. And this woman makes it happen. She'll call you middle of the night, go take the cookies in the day, 12 o'clock in the morning. She's talking to the community, and she's a professional too. It's amazing to see the number of doctors that you guys put together. You don't only have one psychiatrist with the lack and the shortage of mental health, but we have two here. The panelists have been amazing. So congratulations on that effort. Hopefully, this will really change the way policy, law, and mental health get together to finally make a difference in the world. So thank you very much for this panel. It's amazing. God bless you.
Thank you.
Good morning. I'm Lena Elsteroff, a family physician, and yes, thank you for putting this forum together. My question is, has anything been explored to see if psychiatrists can come out to community health clinics and really improve the access to some of these patients? As we know, the barriers are the level of trust in the system, financial, transportation, and really providing that warm handoff and supporting physicians who have about 20 minutes with each patient to really deal with the mental health issues and social determinants of health.
And that is the direction that we're headed. I think this is really the future of health and mental health. I don't know if folks know the departments of health, mental health, and public health are now combined under one agency, and that's with the express purpose of creating those kinds of collaborations. So right now there are pockets where that's happening. So for example, East San Gabriel Valley has healthcare clinics in it, and right now we have our clinicians. who are in healthcare settings. So we have them at the DHS clinic sites to help be available for consultation and supports. And DHS has developed something called an e-consult line. So, but right now that's department to department to make sure that primary care physicians have access to psychiatrists. I think the next step is really making those services all, and what I'm hearing is in one site.
Yeah, I think it's important, especially the face-to-face connection in mental health. Yeah, thank you.
So, yeah.
Hi, my name is Claire and I'm a mental health provider in Pomona. And I was wondering, you mentioned the health initiative in San Gabriel Valley. There is a monthly meeting in West Covina.
Yes, the meeting is on the second Tuesday of every month at Masonic Center in Covina. So if you have a card or if you have a contact information, my contact information is on the table.
Okay.
Feel free to just email or call me and then I will put you on the distribution list. That way you can get meeting reminders.
Okay, and my second question is MTT accessible countywide? Like in SPA 7?
What is MTT? Sorry?
Mobile.
Oh, SB 82, the homeless mobile triage. Yes, they're countywide.
Okay.
So every spa has a team.
Okay, thank you.
List that you have there with the service area navigators, they should know who their local SB 82 contacts are if you're looking to make a connection with SB 82 in a different service area.
All right, Kayleen and Evelyn, thank you so much for being with us today. All right, so good news, lunch is here, and we're going to take a quick break. So please feel free to help yourself to refreshments and enjoy the resource fair. And in all of your packets, you do have an evaluation form. We would love to get your feedback on the sessions that we had this morning, so please don't forget to fill those out as well. And if you do fill them out, you will be getting a raffle ticket. If you look behind you, Tashira is waving raffle tickets in the air, and we have some great prizes at the end of the day. All right, thank you. All right, everyone, welcome back. I hope you enjoyed the break. I am pleased to introduce our next topic, which is managing fears, stigma, and barriers. Mental health is often seen as an additional barrier to accessing care and patient adherence to treatment and medication. With mental health issues on the rise, it is becoming more important for providers to understand the complexity of issues that may be impacting a patient's health outcomes. With us today, we have Dr. Jennifer McNulty, who is double boarded in obstetrics and gynecology and maternal fetal medicine. She is currently a staff physician at Long Beach Memorial Miller Children's and Women's Hospital, where she is in private clinical practice with 14 other physicians providing outpatient obstetric care, 24/7 in-house labor and delivery coverage, and teaching for medical students and residents. She and her partners care for pregnant women with a broad diversity of backgrounds, many of whom have limited access to mental health services. She often works with those confronted by perinatal depression and anxiety, substance use disorders, intimate partner violence, and PTSD after a traumatic birth experience. She is a 20-year resident of the San Gabriel Valley, where she is the immediate past chair of the Board of Directors of Planned Parenthood of Pasadena, San Gabriel Valley. Welcome, Jennifer.
Good afternoon. Pleased to be with you today. So I want to give you sort of an overview of some of the issues in perinatal mental health, and with a focus on perinatal depression, including postpartum depression. And some of the shots I have up here are from some of the resources that are in your handout with the links, and some of these sites provide really excellent materials. So perinatal mental health disorders are incredibly common, as they are in the general population. And it's estimated that about 1 in 5 or 20% of women will experience such a disorder during pregnancy or in the postpartum time frame. That makes perinatal mental health disorders by far the most common complication of pregnancy, exceeding combined risks for gestational diabetes and preeclampsia, which people think about more commonly. The prevalence, as we all know, for women living in poverty, which is as high as 1 in 2 women due to the social determinants of health, which I think have been touched on already. Unfortunately, most of these disorders are never diagnosed or treated during the perinatal period. And increasingly, the science is showing us that untreated disorders in the perinatal period devastate not only women, but impact their family stability, affect their well-being of their children, and may have lifelong consequences for the fetus that they're carrying during the pregnancy and their newborn infant. Just for some bigger context, in California, the annual births are approximately 500,000, and there's only 4 million births in the nation annually, so that makes about 1 out of 8 births occur in California. And for even bigger context, Canada, our neighbors to the north, deliver about 300,000 babies annually. So in California, we deliver more infants here than the entire nation of Canada. Texas is the next most populous state in terms of deliveries, and they deliver about 300,000 annually. So again, we're 500,000. In LA County, we deliver about 150,000 infants annually. Untreated depression and anxiety increase risk for preterm birth and low birth weight infants. And again, the science is showing us that untreated in utero exposure to maternal depression is associated with changes in the fetal brain and is associated with alterations of fetal DNA, which may have lifelong consequences. These conditions are stronger risk factors for childhood behavioral problems than maternal smoking, drinking, or domestic violence. Impaired maternal bonding is also associated with negative childhood outcomes with respect to learning, health, and adult functioning. And low-income families are disproportionately affected with a higher prevalence of maternal mental health disorders and a lower likelihood that they're going to be diagnosed and treated, further compounding the negative outcomes of poverty. The range of mental health disorders are displayed here. So important to mention that baby blues is incredibly common and in fact affects about 80% of new moms, but occurs in the window of up to 2 weeks after birth and is not considered a maternal mental health disorder because it's so common and is self-resolving without intensive treatment. Depression is one of the ones that we're going to focus on, but also anxiety disorders, which include obsessive compulsive disorder, panic disorders, and post-traumatic stress disorders, which can affect moms before their delivery, but may be a consequence of an unexpected outcome or what she perceived to be a traumatic birth experience or what may have been a medically complex delivery. I'm going to focus less on, or really not at all today, on bipolar and postpartum psychosis, which are much smaller components. This just gives you an idea of the prevalence of these conditions both during pregnancy in the middle column and postpartum prevalence. So if you look at major depression and consider both pregnancy and postpartum prevalence, it's about 12%. Minor depression up to 19 to 20%. And some of these other conditions are, particularly postpartum psychosis affects about 0.1 to 0.2% of women. So a very tiny number. This just displays what I think everybody in this room knows, is that the prevalence of depression and other mental health disorders are affected by the background risk of the background prevalence of poverty. So if you look at the blue bar way over here on the left, and you look at the prevalence in the birthing population by income level, so these are women who are at 0 to 100% federal poverty level, and for a single mother with one child, that annual income is somewhere around $14,000 annually, to give you a sense of that. So 44% of births in California in 2012 to 2013, women fell in that category, and of course they have by far the highest prevalence of mental health disorders. The prevalence decreases as you go up the income scale. This is a really important resource, and there is a link to it in the handout that's available online. So this comes from the California Task Force on the Status of Maternal Mental Health Care, which was published in 2017. And for those who have an interest in or who are seeing women with these disorders, this is a really, in my view, a good resource. It came about after the California Legislative Women's Caucus introduced legislation in California, which passed, which as a result of that legislation, a task force was convened to really look at the state of maternal mental health in California. This task force was a multi-stakeholder effort which convened over the course of 12 months. It was multidisciplinary, and the number of work products came out of that. They included in that what provider core competencies for all of the different types of providers who would interface with these mothers, including pediatricians, physicians, ancillary healthcare providers, lactation specialists, a whole spectrum of individuals who might be caring for such a woman. It included a continuum of the time frame for which we should be identifying, screening, and putting together treatment planning. They identified what cutoff scores should be used for the most popular screening tools, and I'll talk about that in a minute. They also provided a menu of prevention and treatment options, which should be discussed with women, and I'll show you that in a moment. And it was also a call to action for the various stakeholder groups with a detailed roadmap for future improvement of care in California. The overriding concern were to summarize the gaps in California for maternal mental health care, identify strategies for improvement, and provide a call to action and a framework for future efforts going forward. They identified a number of barriers, which will not be a surprise to those of us in the room taking care of individuals, one of which is that providers lack guidelines, referral pathways, there's not enough capacity, and there's not enough support to screen and treat. Medical and mental health insurance and delivery systems and providers are not well integrated. OBGYN screening rates are not measured, and they're certainly not reported, and data that we do have on this area show that obstetric providers are not doing a good job of this at all, but we're hoping to improve that. Women don't receive adequate support and education, and there's a lack of a framework or roadmap. We know that fewer than half of OBGYNs screen sometimes or always, and not necessarily with a validated tool. And OBGYNs who don't screen say they don't have time, they aren't qualified to screen, they don't know where to refer patients for help, they have high levels of physician burnout, and they see patients infrequently. Pediatricians also may be an important gateway for identifying these mothers, and the Academy of Pediatrics says that well child visits are now an important gateway for which pediatricians should be helping to identify mothers at risk because of the impact on their pediatric patient. Studies also suggest that women prefer talk therapy over pharmacologic interventions, but OBGYN and family practice physicians, when you look at small surveys, seem to prefer medication treatment over talk therapy by themselves. Writing a prescription versus sometimes intense follow-up that's needed, or trying to get patients and clients to other providers. There are many barriers, stigma, lack of transportation, feelings of shame, or previous experiences of feeling judged by healthcare providers. Women of color in particular have lower rates of diagnosis despite higher prevalence rates. I'm going to also mention that bifurcation of behavioral health services from health insurance plans is one of the problems that we have. And the California Task Force has called for medical insurers to bring mental health in-house and to improve rates of that. Within the Medi-Cal population, severe mental illness is typically addressed through and is the financial responsibility of the departments of mental health throughout California's individual counties and jurisdictions. But many of the women that we see with maternal mental health disorders, postpartum depression, don't qualify for care unless they have chronic or persistently severe illness. So the more mild and moderately affected women, we really need to do a better job in their home base, which ought to be OBGYN providers oftentimes. The tools that are validated and are recommended for screening include the Edinburgh Pregnancy and Postnatal Depression Scale, which is what we use in our practice. About half of our patients are covered under the Medi-Cal program in my setting, and also the Patient Health Questionnaire. Both of them use a cutoff of 10. All pregnant and postpartum women should be screened according to the American College of Obstetrics and Gynecologists as of 2015. The U.S. Preventative Services Task Force recommendation as of January of 2016. The Council on Patient Safety and Women's Healthcare, which is a national organization focused on reducing maternal death and morbidity in the nation. The Academy of Pediatrics, and CMS. So all of our professional bodies are telling us we need to step it up and we need to screen women on a regular basis. But screening, the context for screening is really key. We have to establish trust with women. In our office, we normalize at our first prenatal visit the concept that these are very common disorders, that we're going to ask about their antecedent history, which places them at risk, and we're going to use that as a springboard to talk about warning signs and things, the concept that we're going to be caring for them all through the pregnancy and through their postpartum trimester. We're now calling that the 4th trimester. And that mental health falls under the scope of what we are doing as a provider for their pregnancy. We normalize the prevalence of these disorders. And we raise awareness, ideally, as providers, that treatment is available and women do get better. And as particularly when we talk about postpartum depression, treatment works. And so there's a message of hope there, and patients need to be aware of that, or they're not going to be comfortable disclosing to us. It's recommended that we use a screening tool at several points now. We use it now at our initial intake so that we can identify risk factors that, or problems currently going on. 3rd trimester, it's also recommended that we screen, as well as postpartum at least 2 points in time. And we use those screening scores to open up a conversation. This comes from the task force white paper that I mentioned, and it just gives you a sense of the number of different potential treatment options for maternal mental health. And I'm not going to go through all of these, of course, but there are many different avenues to treatment, and usually this involves a multimodal approach. And bringing the patient into the conversation about what makes sense for her and using step therapy is a really important part of this. So we educate ourselves. We use continuing medical education. I've listed here a number of online resources which have really wonderful, a variety of different wonderful documents. The 2020 Moms I particularly like, and they were sponsors of the maternal task force in California. They actually have an online training module now that's available for clinical providers that really gives a really great overview of maternal mental health issues. We talked about educating our patients and normalizing that this is a very common thing and that we are there to provide that type of care. And we do universal screening in our practice. We discuss self-care, which includes nutrition, exercise, sleep and rest, time for self and support as an important part of this. And we have to identify the resources in our own community. And we have several folks in our office who are repositories. Every time we send someone out and connect them with a therapist or another resource, we ask that individual to give us feedback on how that went with that provider. And if it was a good one, we add them to our list of people that are part of our team. There's a number of different resources available in Los Angeles County. Long Beach is part of LA County. Lactation support is critical because that can be a significant source of stress and can be a risk factor for postpartum mood disorders. And we use patient handouts and written materials, many of which we obtain from some of these online resources. The important thing here is follow-up, follow-up, follow-up. And we know that treatment of maternal mental health disorders, particularly postpartum depression, requires many follow-up visits. And sometimes, because it takes a while to get women into the care they need with a therapist or another provider, in the meantime, they need to keep seeing us. So that means I don't just give them a referral number or say my insurance person's going to get you in through your managed care plan, because that may take 3 or 4 weeks to access. So in the meantime, she needs to keep seeing us. And that may not be because I have the answer when she comes to see me, but what it tells her is I value where she is, and I am there to continue to provide essentially mini talk therapy. And do we need to start medication therapy? How is lactation going? Who is she getting to support her? We continue to use those screening tools. So patience is really important. I'm not going to talk about initiation of medication therapy because my time is up, but that is sometimes an important part of what we do. And reassuring women about the use of that in the setting of pregnancy and lactation is a barrier, and one that we have to be prepared to address. So I think with that, I'm going to stop and go to the next person. Okay. All right. Thank you for your time.
All right, thank you so much. Thank you so much, Jennifer. And we'll have time to dive in to more of this during the question session as well. And now I would like to introduce Dr. Chinam Hathik, who was born and raised in Southern California, where he developed a passion for community medicine as he worked in a medically underserved area. Upon completion of his residency program and board certs in family medicine, Dr. Hathik joined East Valley Community Health Center, a federally qualified health center that serves the San Gabriel and Pomona valleys. He currently works there as a lead physician and the chief medical officer for their 5 community health centers. He's also an attending physician and oversees curriculum development in the family medicine residency program at Citrus Valley Health Partners in West Covina, California. All right, welcome, Chinam.
All right, so I promised them I would take about 4 minutes. Let's see how that goes. Actually, a little update. It's actually 6 facilities now. We just opened up a new school-based health center. So good afternoon. Thanks for coming, and thank you for having me. Again, I'm Dr. Chinam Hathik. I'm a family medicine trained physician. Why am I here? 1, my father's a psychiatrist. 2, my brother's a psychiatrist, so I know the stigma behind talking to psychiatrists. Very, very, it's painful, but that's another talk for another day. I come to talk to you about how we integrate behavioral health services in an FQHC setting. So who are we? We're a group of FQHCs that serve the East San Gabriel and Pomona valleys. We serve about 25,000 unique lives with about 100,000 visits a year between our 6 facilities, again, 3 of them school-based. We are PCMH designated, and we have a homeless clinic on the horizon. In our facilities, we provide primary care, dental, OB-GYN, prenatal, and pediatric services. We have an HIV hepatitis C treatment program. We have homeless outreach. We have primary care services on a mobile clinic for the homeless outreach. We have optometry. We have a MAT program, a medication-assisted treatment program for our opiate addiction. And we have nutrition services through our RDs. And also we have our family medicine residency program through Citrus Valley Health Partners. So how do we put primary care and behavioral health together? Yeah, that's a big topic, right? So in our medical centers or health centers, we have care teams. So our care teams consist of our medical providers, either a physician and 2 to 3 mid-levels, their MAs, an RN, a behaviorist, which is an LCSW or an MSW, and an RD. These teams meet about 2 hours every week. They have 2 hours of protected time to meet and talk about patients. During this time, they could talk about anything, difficult cases, problematic cases, and then for a good amount of time, they start planning their whole week out. So we have huddle lists for all our patients. So we have a pretty robust QI department that facilitates this process for the teams. A list of their next week's patients are printed out, and on these lists hold some vital data, including behavioral health data. In these meetings, the behaviorist and the care teams will talk about, okay, what services do we need to coordinate? and also talk about barriers to treatment. For example, if we notice some patients have been no-showing multiple times to their visits, we can talk about it and figure out why. Why can't they come to their visits? Is it a stigma? Is it as easy as something as transportation? So we can address those things beforehand, before the patient gets there, or coordinate to have these patients brought to the clinic. With this, the behavioral health is heavily integrated into the day-to-day of the care teams also. We all know that primary care usually runs on time. There's very little wait time for the patients, and physicians have a lot of times with their patients, right? Not really. So what tends to happen is when the medical provider is running behind, the MSW is always on the floor with the care teams. Through those huddle lists, those pre-huddles, they can identify patients, or through direct consultation with either the MA or the provider, insert themselves into the visit. What does that look like? If I am seeing patients and my next patient is already roomed, they have a high PHQ-9, the MSW will insert themselves into the visit before I even get there. Or if I'm running on time, insert themselves after. We find this to be a very elegant way to address this problem because, one, we can't bill twice in one day for a patient. An MSW cannot bill, so might as well use their skill set to the highest part of their ability so we could facilitate as many services as possible. If that MSW does that brief intervention and determines that this needs to be bumped to a higher level care, they will schedule to have an appointment with an LCSW. So we've been doing this for the last year now, and it's been working out, actually really not seamlessly, but very close to seamless. The medical providers really appreciate having that behavioral health support on the floor, especially on the fly. A lot of our patients will come in and say they're here for their medical issues, but then at the end say, well, I have these issues at home, whether it be domestic violence or housing insecurity or what have you. At this point, the medical provider can contact the MSW to insert themselves to provide more services. And since we are a patient-centered medical home, we can provide all the ancillary services at once. For future projects, so like I mentioned before, we have a pretty robust QI team. The QI team just goes through all our EHR data and helps us target our ancillary services. One of those services is medicated assisted treatment. So we can now identify those patients that have been on opiates for more than 8 weeks and are currently on opiates. With that data on hand, our CDAC, our Certified Drug and Alcohol Counselor, can insert himself into the visit also to pull those patients over to other treatment services. Yeah, that's how we do it. Screening. So another question was, how do we screen our patients? So, I think it was mentioned earlier that, patients wait, to see the physician, so they have to fill out paperwork. So I think in your packet, you have an example of our behavioral health screening packet, our behavioral health screening tool. It's a one-page screener that contains the PHQ-9, the GAD-7, the audit C, and cage questions. With this, how this works in the workflow is after the patient fills this out, all the packets are collected, put in the MSW's hands. They screen them real quick and go through and pick out the high scoring ones. That's another way the MSW can insert themselves into that day's visit. The low scoring ones, they will input them into the EHR after the fact. And with the moderate ones, they can triage those and target them as needed. That's about it. How did I do on time? Well, I'm done, so that's what we do. All right, thanks.
I'll invite you up for questions. And if anyone has questions, please feel free to line up at the microphones on either side of the room.
Yeah, no worries.
Awesome, thank And I'll just, I'll go ahead and start us off with a question that I had. Or sure, if you'd like to start us off really quick.
Hi, my name is Deborah Navarez. I serve as a therapist at an FQHC.
I'm sorry, could you bring the microphone down a little bit?
My name is Deborah Navarez. I'm an associate MFT at an FQHC in South Los Angeles, South Central Health, a Family Health Center. Basically, my question is for the doctor. We have a large number of illiterate folks. How do you address that with the SPURT, with the FQH, with the PHQ-9, with the GAD-7? Because in our workflow, that's a challenge.
I guess it's me. So with the illiterate population, when we notice that the form hasn't been filled out, the MA will approach them and ask, what are the barriers to filling this form out? If it's noted that they are illiterate, they will go through the form verbally with them.
Okay, and what's the average time that the MSW can spend with them?
It really depends on how slow the medical provider is. The MSW can spend up to 15 minutes with the patient doing brief interventions.
Okay, and do you have solution focused, or do you let them know it's like, look, you have 10 sessions with us, 30 to 45 minutes each, or from the outset to let them know what they can expect?
Yes. Our MSWs do have a limited number of sessions that they can provide for the patient. Our LCSWs can escalate that to a higher level if they needed to.
Thank you.
All right, so I wanted to ask you both about the topic of trauma-informed care, because I think that's something that is starting to bubble up in a lot of our practices. What sort of suggestions or tips do you have for providers about easy ways they could start to incorporate some trauma-informed care practices into their overall practice?
Yeah, that's a good question. When we do our intakes with our folks, we are definitely looking to identify past areas of trauma when we take that intake history. So in our office, we use forms that come from the College of Obstetrics and Gynecologists, and there are questions in there that are designed to help us identify some of these past traumatic experiences that then we need to incorporate into our care plan with that woman. There are also clues in our care that she may not self-identify as having an issue that we have to be on the alert for. So I think for us, an important part of that is just making the identification that this is a woman who's at risk. In the postpartum period, this is also a really key area for us because we've had the experience of being part of that woman's delivery. And many times those women have had an experience that, because a lot of my patients are complex and may have a complicated delivery, or they may have had a delivery experience which is different than what they were expecting. And so they may perceive that as traumatic. So it's not my identification of what's traumatic, it's hers. And so we need to be on the alert. We are asking questions in the hospital of our care team to try to identify the women who seem to be having greater difficulty even in the hospital. And those can be predictors of who's going to need early intervention when they go home. And the last place that I would say in obstetric is when I see a patient for her new intake, a lot of times her previous obstetric history is what I identify as being her trigger. And when we think about trauma in the perinatal period. So those are women who I take a routine history and that woman starts crying in the middle of that history. Right away, I know we've touched a tender spot that she may not have even processed in the 2 or 3 years since her previous birth that we have to address. So all of those things come up in my field.
In our primary care setting, I think the best way to attack this issue is splitting it into 2 kinds of trauma. We have acute trauma, past or chronic trauma. But the solutions are very similar with our MSWs and LCSWs on the floor. We've also developed a pretty robust policy on mandated reporting. Oftentimes we found that if a primary care provider got a hold of that information, a lot of that mandated reporting just gets pushed to the top, and a lot of ancillary care services aren't brought in to help. Meaning they'll get the legal help, but not the supportive help, especially in mental health. So we have it mandated in our policies that if there is a mandated reported event on the floor, the behavioral health department gets pulled into that. Since the LCSWs are mandated reporters also, they will be doing the reporting based off of what they find and relieve the medical provider who is, one, probably stressed out, two, behind in patients, three, don't have as many tools in their tool bag to deal with this issue as the mental health provider. So if it comes up in the screener or if it comes up during the visit, the MSW can be pulled in fairly quick right after the visit. And there could be a warm handoff from the medical provider to the MSW to help facilitate further care.
Thank you. I wanted to shift gears a little bit and just ask a question around something that sort of came up in both of your conversations, and this is around marginalized populations and their experiences with trauma that really impact health outcomes. And Dr. McNulty, you started to touch on this a little bit when talking about perinatal health outcomes, specifically in a socioeconomic context, but I think also there are a lot of complexities when it comes to other marginalized populations, such as people of color. I was wondering if each of you could sort of speak to that a little bit from your perspectives.
Yeah. Well, thank you for bringing that up, because that is a very, very important topic. And increasingly, we are, as obstetric care providers, you know, the science of obstetrics is really beginning to tell us that the disparities that we see in our health outcomes in the pregnancy for pregnant moms, just around something as simple and straightforward as maternal mortality, as well as maternal complications, and on the infant side, low birth weight, childhood death in the first year of life. So all of these outcomes, we see anywhere from a 2 to 4-fold increased risk for African American women in particular. And in obstetrics, we have spent a lot of our scientific focus, if you will, on interventions during 9 months of pregnancy to try to close those gaps and to improve outcomes for everyone. But the problem is that that is too little too late, probably. And so we're really learning about the, you know, adverse childhood experiences, the experience of lived racism in this country, that those are really providing chronic stress to our mothers that is propagated through generations. And so for us to get our hands around that issue, we're going to have to do much more than just focus on 9 months of pregnancy, although that's important in my world. But we've got to go well beyond that, or we're not going to close that gap. So I think that's the first thing that I would say.
Where to start? Okay, so coming from an FQHC, our patient population in the East San Gabriel Valley tends to skew on the older demographic, so 35 to 65. Also high Latino population and higher levels of poverty compared to surrounding communities. So that's what FQHCs do, right? We kind of have to treat everything medical and outside medical. That's why we have these ancillary services. We cannot just treat our diabetics one way. We have to help them facilitate their own treatment at home, whether that be through nutrition or transportation or promotores or what have you. There's no one size fits all for any community, because everyone has different needs. That being said, having as many tools as you can to attack this problem kind of helps you push new and innovative initiatives along. That being said, I think data is one of your best ways to not just identify, but to also just really get down to what's going on, what's the root cause of the problem. Having your QI data to say, okay, our patient population in this one clinic, for example, their A1Cs are really high. What are the social determinants of health? And we could do deeper dives. We've done that at our school-based clinics. We have a small school-based clinic in La Puente, for example, that is landlocked. When I say landlocked, I say on one side there is a major street and rail tracks, and the other side hills. And then around it is industrial. There's no access to green spaces. There's no access to fresh groceries. Transportation is very limited. Even information access to information, internet access to that area is very limited. So what do we do within our clinic in the middle of this community? So we provide that information. We help with transportation. We have food banks and food pantries come out. We have things of that nature to help combat these issues. Because mental health is an accumulation of everything. You know, if you have chronic disease, I forgot what the numbers are. You're 6 months of chronic disease, you have a 4-fold increase of depression, and actually vice versa. Chronic pain causes depression, and depression causes chronic pain. So we can't talk about mental health without talking about physical health, and vice versa. It's all in one. So I think it's been far too long to not have these two integrated. So I guess I'll just leave it there.
Thank you. Yeah, I think that's a great place to leave it. We do have a question over here that I would like to address as well.
Thank you for both of your presentations, very informative. So at an FQHC setting, which I also work at, I'm just wondering the funding issue regarding mental health clinicians, especially if they're providing the services the same day and you don't get reimbursed. So how do you manage that to get a full-time mental health clinician on the floor every single day?
My CEO is really good with budgets, and we have a really awesome CFO. We make it a priority to put funding into these areas, even if they're not making money for the clinic. We understand that it's probably going to be a sinkhole for funds. However, and I don't know how to measure this, and it's hard to, we feel that the positive outcomes from funneling our resources into mental health outweigh the actual physical cost, or the monetary costs.
That's great. Thank you. And I commend you for meeting 2 hours a week and really going over the high-risk patients. I think that's really an effective way to manage high-risk populations.
Our providers love that time, that productive time.
Awesome. Well, Dr. McNulty, Dr. Haddock, thank you so much for your time. This was a fantastic session. Now we're on to our final session of the day, special populations in mental health. So, I mean, as we've heard today, the element of diversity really does add complexity to the barriers, stigmas, and fears that might impact a patient. LGBTQ people and people of color have higher rates of depression and suicidal ideation and are typically the least likely to seek out resources. As providers, how do we address the needs of special populations in mental health? With us today, we have Dr. Carolina Bowe. Carolina is a mental health therapist at Pacific Clinics who provides counseling services to older adults who are affected by depression, anxiety, grief, loss, and challenging health conditions. Her interests center on culturally competent support, interventions that focus on empowerment and spirituality, and education about mental health challenges, such as overcoming mental health stigma. In her practice, Carolina emphasizes the importance of resiliency, persistence, and affirmations of self-efficacy. At the macro level, Carolina also coordinates outreach activities that promote the clinic's prevention and early intervention program, aimed at providing mental health services to older adults in the San Gabriel Valley. Carolina is a licensed clinical social worker who holds a master's degree in social work from the University of Southern California and a bachelor's degree in economics from the National Autonomous University of Mexico. Welcome, Carolina.
Hello, everyone. It's a pleasure being here and an honor to be invited to talk to you and having this wonderful opportunity to be. I'm officially nervous because I can see faces, very sharp faces, very intelligent people here. And I wish I can make a good impression of you and talk about my passion. My passion always was being to work as a mental health therapist for older adults. And I got to get my position like a mental health therapist at Pacific Clinics in the older adults. So the population I serve is mainly Latinos. So what my program do is, because we know that the mental health is unrecognized and untreated among older adults. We work to raise awareness about the symptoms of the anxiety, depression, and substance abuse use. And we offer treatment and interventions to them in order for allow them to recover from their illnesses. And our clients receive counseling services and management, case management, and also medication management. And we provide our services either in our office or in the home of the persons, because some of our clients are so bedbound that they cannot go to get their services with us. And we provide the services in Spanish, English, and Armenian. So the kind of clients I serve I work with two types of clients. One, the ones that are very, I can place them in a preventive program. So then it's only 25 sessions. Those are my PI clients. It's preventive and short-term treatment. And they basically, it's people with mild to moderate depression or anxiety or combination of both, or face physical health challenges or job career challenges or life transitions, losses of independence of loved ones, or those who are so overwhelmed because they are caring for someone in their family that is ill. So caregivers are also some of my clients. So there is the other type of clients that they have more need of longer treatment because they are they need a higher level of care. Those are my OAP clients. Those are with severe depression or anxiety, schizophrenia or bipolar disorder, something like that, right? So what I do is I engage in outreach activities and promote the admission of my PEI clients, my preventive clients. When I have the referral, I just screen that person, see if he or she meet the criteria, and then if the person meet the criteria, so then I proceed to enroll the person in my workload. But if the referral does not meet that criteria, so then I provide referrals to other providers, so then they can get attention. As I previously mentioned, I provide mental health services to primarily Latinos. Latinos are not different when it comes to prevalence of mental illnesses or stigma when compared with other population, the rest of the population. But in the Latino population, they are different in such things that as Latinos understand mental health in a different way. They have different way to understand the illness, and they also have different way to cope with those illnesses. So common mental disorders among my population is a generalized anxiety disorder, major depression disorder, post-traumatic stress disorder, and alcohol abuse. Those are mainly the most common causes for which they come to us. There are many barriers that my Latino population face. Those are, among others, is a lot. I guess it's the same for other populations, but it's concerned about the social stand of the job. They are obviously very afraid to say, I have an illness, I need help, because they say, no, probably in my job, they're gonna say, I am loco, I'm a loco, I am, crazy, so I will lose my job. So, or people will criticize me. They also have inability to recognize their mental health symptoms. They face language barriers, mistrust, lack of information, which increases stigma. They have fear to disclose or rejection, fear to the rejection, to be discriminated. And they have fear to be labeled like locos or cowards or weak. So also there is another thing very common in the Latino population. They have privacy concerns. They say, la ropa sucia se lava en casa, which means don't air your dirty clothes in public. So it's yours, it's your problem, you deal with that. Okay, there is misunderstanding about mental health. There is also misdiagnosis, and some Latinos prefer more to rely in home remedies and traditional healers for their illnesses. So that means that they don't look for help from health providers. And there is another two things. It's legal status, they face legal status, and they face lack of insurance, many of them. So overall, it's a stigma all prevails among Latinos can be in the form of self-stigma or the internalized feeling from the stigma, from the belief that others label them is internalized, or public stigma. And stigma is a very, very powerful and affect very much people. It's not only the people that is ill, they are dealing with the pain of the illness, and they are dealing with the pain of, they cannot talk about the illness. They cannot look for her. So I don't know what is worse, the one or the other. But they have stigma have devastating effects such as diminished sense of self-efficiency, efficacy, low self-esteem, isolation. This is isolation. They isolate from people, or people doesn't want to know anything about that person because they know that person has a mental health illness. Okay, so then overall they have the tendency to don't look for help from providers. So among Latinos, it is almost a taboo to talk about mental health illness, and I have seen it. When I put my table in an outreach community, they look mental health, and then they go, they just run. Los loqueros, okay, No, I don't have anything. I am okay, okay? I just came for a pen, okay? All right, that's fine, or a cookie, okay? So I know that, but they talk about mental health when it's when there are crises around, or when somebody commits suicide, or it's a shooting. So then they talk openly about mental health. So how do I work with my population? Okay, since the very first encounter, I try to feed them their soul with hope. Hope by talking about some of the facts of mental health. So the facts more or less are that mental health issues occur in almost every family, regardless their culture. So then they feel that they are normal. They feel that this is normal, that it's that illness around. So people with mental illness can recover or move forward toward recovery when they receive support. I mentioned too much support from peers, from family, from friends, from community, and especially from mental health providers. And I explained them that this is possible also to move forward recovery or recover when they bring to them, they use their inner strength, their resilience. I tap in the spirituality if it's possible, promote the self-care strategies, look for ways that they see what kind of supports they have and access those supports, and tell them that they have to develop a sense of connection with what is around. So also is the idea to let them know that they're not because they are mental health sufferers, they cannot be a contributor for society, because they can be very good contributors for family, for community, and also for professions in mental health professions, right? So I also explained that, try to explain them that any part of the body can be ill, so especially the brain. The brain is part of the body, so we are a whole. So that it is normal that we sometimes feel ups and downs in response of what happened in our lives. But mental health conditions go beyond those emotions, because they cause changes in the way we think, the way we feel, and the way we act. And I explained them that without proper treatment, all these mental health conditions can be worsened and can be very, make our day-to-day life very hard to follow, and because they create those mental health ignore symptoms. And sorry, I'm a little bit nervous, but they can create affect life performance, they can affect social relationships and physical health. It's very important for me to let them know, okay, if you don't treat it and you are diabetic, if you don't treat your depression, you will be probably adding more sugar to your glucose level, right? And vice versa, because everything goes connected. So in my practice, in my program, we use evidence-based practice interventions, such as IPT, IPT, seeking safety, problem solving, and CBT. So clients discuss their problems and learn the new skills. They gain insight into their thinking processes. And they learn healthy coping skills, and they learn also grounding and deep breathing and relaxation techniques, So then they can control and manage their symptoms, and they can improve a little bit. So that is my job. That is something that I do with passion, and I hope this was not too repetitive, because I hear a lot of talking about that from experts. So I'm not an expert or anything, but I am a very passionate person for what I do. And thank you so much for allowing me to be in this stage. I don't know what I'm doing. That is yours.
Exactly. All right, and now I would like to invite to the stage, we have with us today the San Gabriel Valley LGBTQ Center, and with us we have Erin Saenz, the board president, and Sarah Marie Acevedo, the secretary of the board and director of programs. So we could have you both please join us on the stage. Welcome.
So again, my name is Erin Saenz, and I'm the board president and one of the co-founders of the San Gabriel Valley LGBTQ Center, and that's a mouthful. So after we say it once, we just say the center. It's easier. Today I'm going to tell you a little bit about the center and what we do, a little bit of our programs, and then Sarah is going to present findings from our first needs assessment. The center, we started in 2011. It was a group of community members who came together and, were tired of having nothing in the San Gabriel Valley for the LGBT community. So we came together and we did the documentation to open up a nonprofit 501c3. And we did that in 2011. And in 2015, we kind of launched some programming and started going along those lines. In 2016, we conducted the first ever needs assessment, because I always say a lot of us, we all have our day jobs, and this is our gay job. So it's what we can do on the side, because we are 100% volunteer. We don't have any staff. We just got our physical location at the end of 2016, early 2017 in Arcadia. We launched the needs assessment, and it was the first time we had ever had data specifically about the San Gabriel Valley LGBT community. We had data before from LA County, but if you looked under the hood, it was mostly West LA and West Hollywood, which those of you in the San Gabriel Valley know, it's a different population completely. So some of our programs center around peer support. Again, we don't have staff. So we decided as a board, what can we do that could still help? Peer support. And we have those in LGBT senior, youth, addiction recovery, and transgender. And then we have an umbrella group that we call Queer in the Burbs. And then the second program is community education. So we do an event called Pride Talk, where we kind of modeled after the TED Talks. We bring in people from outside to educate our population. And then we just launched a safe space training that we've been doing at local schools and businesses to help them understand the LGBT community. And then our third program is community building. And so we are working to bring the community together, because it's really hard when, there has never been a center before. So we need to build our community up, connect them. And then we're working into launching advocacy, so we can start working with city governments and advocating for the community. So that's about the center. That's our programs. And so now I'm going to turn over to Sarah.
Hi. I have my notes on my phone. I'm not just like texting while I'm presenting, y'all. So in 2016, a Gallup poll discovered that 4.1% of Americans identify as LGBTQ. And for reference, that's approximately 13.5 million people. These numbers have continually risen as years have gone by. And importantly, these statistics only reflect those who willingly claim LGBTQ identities, so it's not really a full picture of LGBTQ Americans. LGBTQ people disproportionately experience mental health difficulties, partially due to minority stress and lack of social support. LGBTQ individuals are almost 3 times more likely than the general population to experience a mental health condition, such as major depression, generalized anxiety disorder, and according to National Alliance of Mental Illnesses. LGBTQ youth are particularly vulnerable with higher instances of mental health conditions, drug and alcohol abuse, and suicidal thoughts and behaviors. As we aim to serve the LGBTQ community in the San Gabriel Valley, we keep these statistics in mind. In 2015, we conducted a poll of LGBTQ people that Erin formerly mentioned of the San Gabriel Valley and discovered that we needed more services for transgender people, senior citizens, and immigrant people. Recently, our general feedback has indicated that we also need to reach those with disabilities and LGBTQ youth. Our poll responses also highlighted some particular areas of concern for LGBTQ people in the San Gabriel Valley. For example, 20% of respondents indicated that they had sought or received some type of mental health counseling within the past year. 24% had sought or received treatment for depression, and 19% for anxiety. In addition, 83% of respondents said they were not aware of any LGBTQ services provided by their city. So what we do is we mostly referral out. We get a lot of calls at the center that say, I'm having suicidal thoughts, I got fired from my job, I have nowhere to live, and these all disproportionately affect mental health. And we mostly referral out to mental health services because we don't have a mental health professional on staff. And that's pretty much all we have for you. So we'll take questions after.
And now last but certainly not least, our final speaker for the day, we have with us Carolina de la Pena. She is the Patient Resource Coordinator for City of Hope. Would you like to come on up?
Good afternoon, everybody. I told Nancy earlier that if I pass out of here, that she better know CPR in order to pick me up from the floor. So thank you for having me here today. In my role, I indeed have both the honor and privilege of working with some vulnerable patients who, after a cancer diagnosis, face a multitude of psychosocial barriers when accessing care. And it's no secret that vulnerable patients struggle financially and oftentimes face educational barriers that further prevent access to mental health services. So if you combine that with mental health stigmas and the lack of quality providers, you have a perfect recipe for disaster. Barriers to mental health care access are significant issues facing many Americans. More than half of adults with mental illnesses in the US do not receive mental health care treatment. That statistic alone is cause for concern, but mental health issues are far more common than most people realize, and I think everybody in the room here knows that, right? And according to the US Department of Health and Human Services, 1 in 5 American adults have experienced a mental health issue, and 1 in 25 Americans live with a serious mental health illness, such as schizophrenia, bipolar disorder, or major depression. Given those stats, barriers to mental health care access come with a high human cost. In order to increase use of mental health services, we first have to understand what prevents people from accessing them in the first place. So throughout my career, 5 barriers to accessing mental health services consistently come up. At the top of that list is affordability. Even after the Affordable Care Act required medical insurances to provide coverage for behavioral and mental health care, the cost of treatment oftentimes limits access to mental health services. For many individuals, a lack of financial resources prevents them from seeking help at all. For others, a lack of financial resources can lead to inconsistent or inadequate treatment. Even with insurance or financial assistance, mental health care services can be costly. Co-pays and deductibles add up quickly when diagnoses require regular therapy, complicated medication management, or intense treatment programs. The second barrier I see is a lack of mental health professionals, and I think, again, we've heard this throughout the day today. While the US is facing an overall shortage of doctors, the shortage of mental health professionals is steeper than any other category. And according to the Health Resources and Service Administration, 89.3 million Americans live in federally designated mental health professional shortage areas. This overall shortage of healthcare providers is compounded by other factors. Rural areas often have few to no mental health care providers at all, let alone providers with specialties. Urban clinics and providers often have long wait lists, and patients can suffer for months before they get a basic intake appointment. Again, something we keep hearing over and over today. To make matters worse, inadequate reimbursement for government and private insurance plans means private clinicians are only accepting patients who can pay out of pocket. And that is something that we see primarily here in LA, in the West LA area. Try finding somebody who accepts insurance and you will be searching for days. So those factors can make it very hard for someone to find affordable mental health care close enough to their home or work to get reliable and consistent treatment, as is the case for many of our City of Hope patients who live in remote areas. If that's not enough, patients with straight Medi-Cal can only access services through community clinics, and some HMO plans force members to complete a telephone screening before they can obtain a referral. The third barrier is a lack of mental health education and awareness. Again, another repeated theme throughout the day. Physical injuries and illnesses are typically obvious, but mental health illnesses, however, are often hard to recognize. Often symptoms are subtle and might be dismissed as personality or attitude issues. Clinical anxiety may be dismissed as worrying too much. Depression can often look like laziness or fatigue. Even serious conditions may not be obvious to the person suffering or those around them. And this is, again, something that everybody in the room, I think, is pretty well aware of. So if a person doesn't know something is wrong, they are unlikely that they will seek treatment. So a lack of mental health education and awareness keeps patients from accessing care. And fourth, social stigma of mental health conditions plays an enormous role in accessibility. Multiple studies have found that stigma associated with mental illness often prevents people from accessing treatment. At the end of the spectrum, on one end of the spectrum, their beliefs about mental illnesses can prevent them from acknowledging their illnesses or sticking with treatment. On the other end, the very real risk of facing discrimination in social and professional circles creates a huge barrier. I personally can't tell you how many times I have called a patient to offer services, and I get the ever infamous, "Thank you for calling, but I'm not crazy, I don't need a therapist." And last but not least, cultural barriers to mental health care access create significant disparities in mental health care access among different racial and ethnic groups. Another theme of today, right? As we know, minorities are often likely to be poor, less likely to be treated by doctors of their same race, and in many cases, less likely to know they have a condition that requires professional care. In my experience, mental health care is the hardest service for anyone to access, even for people with good insurance. Many people seeking treatment struggle to find a provider that is relatively close in accepting new patients. And it's estimated that over 60% of people seeking treatment are forced to wait 3 months or longer for an appointment. Even when they receive treatment, transportation is often cited as an issue, as the mental health provider may be miles away. So to bridge gaps in mental health care, I leave you with a final thought. As more healthcare organizations continue to expand services for mental health, we must foster a culture of awareness and education to destigmatize conditions that affect millions in our society. Only then will individuals utilize resources available to them. Thank you very much.
All right, now we will invite all of our panelists to the stage for our final Q&A of the day. Again, if you have questions, please feel free to line up at the microphones on either side of the room. Don't be shy. So while we're getting started, I think one of the questions that was, sort of top of mind for me is, what is one thing from your perspective that providers can do right now to address the health concerns of special populations in their practice when it comes to mental health. So what is one thing that you know is sort of an easy lift that people can start to add into their practice?
Advertise your cultural competency. If people see in your messaging that they see themselves in that, they'll be more likely to approach you. Say some stickers for the LGBT community. I always say in our outreach, because the San Gabriel Valley is so diverse, if you're going to put people on there, like trans people or people that, because if at the same time, you're kind of part of the whole San Gabriel Valley, if you put a particular ethnicity or race, then people can have a lot of. So I know it sounds double to everybody, but if you're going for a target population or if you're going for the general.
Would anyone else on the panel like to weigh in?
I think that getting together partnerships are very important. I'm technology. I'm sorry. Okay, partnerships with other organizations in events and educational, providing education in events is something that also can move some of the barriers of stigma and make them see you like a familiar face, and they probably get more usual to, with more interest to go and ask when there is something that really is troubling in their emotions, in their, mental health.
I just want to touch on something that was said. Erin mentioned safe zone training, and Carolina mentioned one way is to fight stigma, and safe zone training does exactly that, and that's something that we offer at the center, how to better serve LGBTQ children. So we outreach to like faculty and staff of K through 12 schools or local businesses, and we train them on appropriate words to say, what not to say, why it's important that you reach them. And I think that really helps. And a lot of people come up to us afterward and say, thank you for telling me this. I had no idea. And so I think that's, if you reach out to local organizations, local nonprofits, not just ours, a lot of people offer trainings, that would be a good step in the right direction.
Thank you. Great, I'll take your question. Hi, Tashira.
So I have a twofold question, and it can be for anyone to respond. I'm curious, have there been any studies in other areas outside of California, focus, or LA County that really look at mental health and perhaps the stigmas that are involved in populations? So I don't have my question formulated very well. Sorry about that. But so I'm thinking about in the South, and I used to live in a predominantly African-American community. And I'm curious, in those types of communities, are in that area, are they facing the same like stigmas of mental health in those areas as we face here, or are there any success rates where there are, people of color that are in those positions as clinicians to provide the mental health, and there's more accessing of that resource? My second question is relevant to recruitment of people of color, or people not even just of color, but in the kind of marginalized communities. Is there more recruitments in schools or programs to pull in or draw in more clinicians to be to gain their studies in the programs to provide the service in the communities where more of the community would access the mental health resource because someone looks like them or is familiar with, them in some way. So I'm just curious about that and perhaps how policy could be involved in some way to help the higher education to do more recruitment in that way. So those are my two questions for anyone who wants to answer.
Easy question.
I have a marginal answer for that. So I got my undergrad in gender, ethnicity, and multicultural studies. So basically I sit around and I talk about race and gender all day. And we were targeted as a population to teach, to go into education, and to also go into being an LCSW or an LMFT because of our background and our familiarity with gender, sexual orientation, and race. But that's just at my college. I went to a polytechnic school, so I don't know if all CSUs or all UCs do that, but we were.
So, and follow up with that, my day job is I'm a career counselor. So I'm always working with mostly adults, but sometimes high school students to give them skills assessments to find out where they would be good at. But I did hear earlier today that NAMI San Gabriel Valley was working with a program to outreach to the schools in Baldwin Park to get people more interested in the mental health careers. So I know that's going on. So. Thank you.
Carolina, did you want to weigh in? Great.
Thank you, everyone. Thank you.
All right. Well, thank you so much. And thank you to our panelists.
Is that it?
Yes.
All right, so I know everyone is as sad as I am that this is the end of our day together. I do want to just say a couple of quick thank yous. One, thank you to everyone for coming for our first annual Mental Health Symposium at City of Hope and for making this possible. I'd like to thank all of our incredible speakers for being with us today and so generously lending their time and their knowledge and their resources. And again, we are sharing all materials, all PowerPoints from today's presentation, so you will have access to those following the event. A big, tremendous thank you to City of Hope and a huge round of applause for Nancy Clifton Hawkins for organizing this event. And the City of Hope Community Benefits Advisory Council's Symposium Committee who put this all together. So we do invite you to stick around, network, enjoy some snacks, pick up some swag from the resource fairs, and have a wonderful rest of your summer. Thank you so much.